I invite Dr. Vidyadhar Vatve sir as the chairperson for the first scientific session. And I also would like to invite Dr. Rohan Jahagidar sir, consultant psychiatrist associated with Chaitanya for the past 20 years or more, to kindly co-chair the next session. For the first segment of the scientific session, we have 3 lectures. We begin with Dr. Manjari Tripathi. Ma'am is going to talk about current aspects of therapy and prevention in cognitive decline. Dr. Manjari Tripathi is a highly esteemed neurologist currently serving as the professor and head of Department of Neurology at AIIMS, New Delhi. Ma'am leads the Cognitive Disorders Clinic at AIIMS and has been instrumental in advancing dementia care in India. As the president of ARDSI Delhi chapter, she played a very important role in establishing Delhi's first daycare center for dementia. I welcome you, ma'am.
Good morning. Greetings from ARDSI Delhi chapter, and we have a daycare center and a chronic care facility. We have an enthusiastic team of volunteers and people to support us. We are doing pretty well in terms of funding, and we are able to sustain ourselves from generous donations made from philanthropists in and around Delhi. I've been asked to talk about a huge topic. It's the current aspect of therapy and prevention of cognitive decline. At the outset, I'd like to thank Ronnie and his team and the Pune chapter for having me here again. I've been here in the previous conference too. So it's a pretty broad topic. It's impossible to cover everything in half an hour. I also understand that the audience is pretty heterogeneous, so I'd like to not make it too technical. But as defined before, we are who we are because of our cognitive capacity. And when there is a substantial decline in that cognitive capacity, which is sufficient enough to ruin our independence and make us dependent on others, then comes the task of identifying whether we have an impairment of cognition. So what exactly is this elephant of cognition? It's a highly complex process which is derived from our senses. It involves complex attention, as you are all giving here, listening me out. It also involves execution, planning, sequencing of events. And of course, memory is an integral part and an overhyped part of cognition. Language, the capacity to communicate, to understand, to comprehend, to speak. And of course, 2 new realms have been added on is the perception or perceptual skills, which includes the visual perception, and social cognition, which was hitherto neglected. So this is a broad area of cognition. So what happens when it declines? Not too much, but mild to modest decline. So when there's a mild to modest decline of this complex body of cognition in one or more domains, which I just listed out, and this is not sufficient. It's insufficient to make us dependent or interfere with our independence, and it's definitely not delirium and not a part of any other major psychiatric disorder. It's called mild cognitive impairment. However, when this impairment is substantial in 2 or more domains, and it's sufficient to make us dependent for our activities of daily living or instrumental daily living, whatever, and it's not a part of delirium or a major neuropsychiatric disorder, it's called a major neurocognitive decline, in other words, dementia. Now, the old concept when I, was doing my DM neurology was either you're normal or you're demented, and there was nothing in between. But we know now that everything isn't like Cinderella's horse carriage turning into a pumpkin over the strike of 12. It's a gradual decline which happens from normal cognition You move on to age-associated, memory impairment, which is still within normal limits. And then you move on to the mild cognitive impairment, which has certain criteria to it. It gives a ground for clinicians to be able to label patients who are not fitting into the criteria of dementia and follow them up. And this is the period where you really want to work on intervention strategies, whether they're environmental or cognitive, etc. And then, of course, you have the major neurocognitive decline setting in towards the end of that. Now, the major part of the cognitive decline which we've gathered to discuss here today is, of course, Alzheimer's, but there are so many other causes: frontotemporal, Parkinson's with dementia, diffuse Lewy body disease, extrapyramidal disorders with dementia, and what have you, and their variants, and FTD, of course. But if you look at Alzheimer's, the whole workhorse of diagnosing Alzheimer's, which we did clinically, has shifted now into a preclinical Alzheimer's setting. That is, the ability to predict that this particular elderly person is going to move on to Alzheimer's. And the emphasis now, or the advance now, is how to recognize this preclinical Alzheimer's disease. Because this is from here that there is a gradual decline, whether it's the MCI due to AD, whether it's mild AD, moderate AD, or severe AD. Now, this has come about and led to evolution in the diagnostic criteria to the current diagnostic criteria, which were research followed by therapy-based now of the NIA-AA framework, which is 2018. So I told you the current diagnostic criteria have brought in preclinical Alzheimer's disease, and this is because most of the therapy is now targeted to detecting this and managing this and getting patients in early. The preclinical Alzheimer's disease is in a setting where the amyloid beta has started depositing in the brain, but there is no clinical manifestation and there is no way to detect it except certain methods. It indicates a decrease in the synaptic functions. We have millions of neurons which are talking to each other. So the synapses are decreasing, their connections are decreasing, so the synaptic function is decreasing. And that occurs somewhere here. There's an echo coming in. यहाँ से echo आ रहा है, मैं जो बोल रही हूँ ना, यहाँ echo रहा है. And then, of course, it moves on to a deposition of abnormal tau, which comes in a little later. And you can see here in the timeline, if this is where you're going to have the clinical manifestations, and this is where you're going to have the imaging manifestations, you really have the onset of clinical AD occurring minus 20 years or minus 15 years from the clinical manifestation. So it's almost 15 to 20 years before the clinical manifestations of mild memory, mild perception, visuospatial perception, mild behavior changes and executive dysfunction comes in 20 years before. And how is it possible to even make out whether a 50-year-old man or woman is going to have Alzheimer's with this preclinical definition? There are certain tools we have. Of course, the key is the clinical history, but that's when the clinical symptoms come in. We do have diagnostic tools. The MMSE is out. We hardly use it anymore. We are doing the MOCA or the illiterate ACE. And at least even in Delhi, there's a 3 to 8 year delay before patients come to us. And I'm sure for a biological or a preclinical diagnosis, it will be more than a 15-year delay. So this is just to show you how in India we can use our own tools. This is the ICMR Mudra Neurocognitive Toolbox, which is devised by researchers which we were associated with. It's there in Bengali, in Hindi, in Malayalam, in Kannada, and of course Telugu. So these 5 languages with researchers all over India who jointly made a neurocognitive toolbox which assesses our patients with our standards and our norms in these cognitive domains. We use the MOCA Hindi. The MMSE is out because MMSE really doesn't tap into the frontal lobes as much as it should and we would want. It's easy to use, both by people who want to get trained on it or who want to use it bedside. Hardly takes more than 10 minutes. And of course, we also have the illiterate Addenbrook's cognitive tool. We do have the detailed toolbox, which is available on the ICMR website for use by all of the students who would like to. And very simple tools for the illiterate are there in this toolbox. So that was the neurocognitive toolbox, which is validated and standardized for our Indian population. However, as I told you, the preclinical diagnosis hinges on certain biomarkers, and these are markers which are available in various of our body fluid compartments, whether it be the CSF, whether it be the serum or the saliva, and serum and saliva are still under investigation. However, what happens in Alzheimer's is there's sequestration of beta amyloid 42 in the brain. That leaves very little in the CSF compartment. So when you do the amyloid beta testing in the CSF, it's way low. It's 50 times lower than what it has to be in the brain. Hence, you derive a ratio, which is the beta amyloid 42 ratio, to the p-tau or the t-tau. So the p-tau or the t-tau is 300 to 400 times higher in the CSF. So you get lower values in the ratio. When you get lower values of amyloid beta 42 to 40 or p-tau or t-tau, it is indicative of a biomarker possibility of a preclinical Alzheimer's disease, indicating amyloid beta plaque deposition in the brain. And of course, the other way to do it is to do the amyloid beta imaging, which is pretty expensive. The PIB imaging is not available in India. The flu beta peer is available, but it's again expensive. It costs about 30,000–40,000 rupees currently. Now the markers for neurodegeneration are of course the CSF tau and the FDG PET, which we have pretty inexpensive, 3,000 at AIMS, I don't know other centers. So really you are able to do the CSF amyloid beta 42 now in India. You are able to do flu beta peer imaging, and we are able to do the CSF p-tau and t-tau. So this is possible that if you have a strong family history of Alzheimer's, or you want to know, there is a memory decline and you want to know whether you are going towards Alzheimer's, a biomarker typing is possible, at least in the CSF. We are doing this so that we are able to define our population of this Alzheimer's continuum, which is going to be either amyloid, tau, and neurodegeneration plus, or amyloid plus and tau plus, or only amyloid. So this is essentially this color, maroon, red, and ochre, which you see here, which is what we define by these biomarker studies for the definition of the preclinical Alzheimer's. Now, how good is this? When you compare a pathological CSF to a normal CSF, those having these markers were about 45 or 42% likely to go on to develop Alzheimer's. Now, when you look at the CSF total tau plus amyloid beta, so you're looking at both tau and amyloid beta, the sensitivity is 85% and the specificity is 83%. And when you look at the neuroimaging biomarkers, which comes in much later, the neuroimaging changes come in much later with decreased hippocampal volume, and correlate it with the p-tau as well as the amyloid beta, it does add value there. So you can combine neuroimaging along with the p-tau and amyloid beta. So we've done the biomarker testing, and there is a positivity, and it is going towards a preclinical Alzheimer's or early Alzheimer's. So what are the options you have? The established options, which are safe and inexpensive, are of course a group of drugs, which is the acetylcholinesterase inhibitors or the NMDA antagonists. The newer ones, which are very expensive, out-of-pocket expenditure as of now, not borne by insurance companies, is the anti-amyloid monoclonal antibodies and anti-tau therapies, which are on the anvil. They all work on trying to increase the memory chemicals in the brain. That would be the acetylcholinesterase inhibitors, 10 milligrams, going up to 23, only in the morning hours, after breakfast. Rivastigmine going up to, say, 12 milligrams, slowly, starting slowly, going up gradually. It's very useful when there are behavior fluctuations. It's very useful even in DLBD. Galantamine, mild and moderate AD, 8 to 16 milligrams. Memantine up to 20 milligrams works on the glutamate receptors and prevents the excitatory neurodegeneration. Monoclonal antibodies, there are two which have been approved by the US FDA, one which is approved by UK, and the UK and the US FDA both agree that lecanemab, which is to be given twice a week, has better effects than aducanumab, and we'll just go through that. So what are these MABs? These MABs are humanized immunoglobulins. These are humanized proteins which have different epitopes. There are more than 7 which are being studied. 2 have gained the FDA approval, which is lecanemab and aducanumab, as you see here. And so let's look at aducanumab. The doses, for both the doses, 10 milligram per kg. And you can see here, lecanemab, which is approved both in the US and the UK. Europe has not approved any of these as of now, but US and UK. Lecanemab is 10 milligram biweekly. We participated in Delhi in the studies of aducanumab, which was weekly. And it has been, the patients were followed up for more than 3 years here, and PET scans were done, and amyloid beta was done in the CSF. And you can see here that lecanemab, which is given biweekly, showed improvement in the clinical symptoms, which reflected in various scores, the ARDSICOG, ADCOMS, and CDR sum of boxes, as well as there were favorable outcomes in patients who had ApoE4 genotype. Aducanumab slowed cognitive decline, which was measured on MMSE and CDR sum boxes, and there were no changes which were seen in these 2 scales. Looking at the adverse effects, lecanemab had low risk of area E and area H, which I'll talk about now, but it had higher risk of area E and H when there was a ApoE4 genotype, as compared to aducanumab, where there was a higher risk for area E and area H. So if we have to use any of these agents in India, preferably lecanemab would be the drug of choice. The amyloid scans, a positive scan showing extensive amyloid deposition, getting depleted of amyloid. And you can see here with lecanemab what happens is when you look at the effects, the downward trend is the worsening, and you see here that there is a better outcome of CDR sum of boxes by lecanemab. Now this is for the amyloid burden on PET. The amyloid burden drastically reduces with lecanemab. ARDSICOG improves with lecanemab. About a quarter of patients will have transfusion side effects. An area which is amyloid related imaging abnormalities are 2 types. The E is the edema and the H is the bleeding or the hemorrhage. And you can see here this is the edema which happens as a side effect to the therapy, and this is the bleeding which has happened as a side effect to the therapy. These are worse with aducanumab. And you can see here about 13% will develop edema and 3% will have severe swelling. The area H is seen in 9% of the controls for some reason and 17% of the trial patients. Now, the side effect of lecanemab is not just the area, it's the cost. As you can see here, it costs about $26,500 US. In Indian rupees, it would come to about 35 lakhs rupees or so, or maybe more. So it's really not something which every one of us can afford. And of course, you will have to do repeated MRIs, which add to the cost. The patient should not be on blood thinners or not have had strokes. And the patient should be in early MCI or preclinical AD. As you can see here in the study, till week 52, you had to do MRIs. So you really have to have an intense follow-up to see if there's area H or area E developed. Now, aducanumab, as you see here, again, made a difference in the CDR sum of boxes. And there's another one called donanemab, which is, still not approved by FDA. I think it reduced the cognitive decline further as compared to placebo. And you can see here that this is the first scan of the patient where there's extensive amyloid beta, and this is the last scan where the amyloid beta has totally been vacuumed off, whereas a patient taking placebo, the amyloid beta remains the same with donanemab. So it seems to be very promising at least. The newer therapies are the tau targeting therapies, which target the tau monomers, oligomers, and aggregates. And they work at different levels, as you can see here. They prevent the aggregation, they enhance the degradation, and they cause what is known as autophagy. So these are the anti-tau deposit mechanisms, and their trials are going on in various phases. You can see here a few have reached phase 3. So phase 3 is methylene blue, which we keep hearing about, and of course curcumin, which we eat in our daily diet. Now coming to the second part of my talk, which is prevention strategies, which will also be taken up by the second speaker. Now health is a very complex entity. It doesn't depend on one thing. It depends on how much you sleep, how much you read, how well educated you are, how much of stress you have, how you adapt to that stress, how resilient you are to various life situations and stressful life events. Depends on how physically active you are. Are you walking around? Are you just seated on the chair as we are right here? And of course the diet you consume, whether you're consuming vada pav every day or you're having sprouts. And of course it also depends on the purpose of life you have. So your health is dependent on many of these factors. Whereas if you have to reduce cognitive decline, you must try to improve all these in various settings. It has been shown by various studies and meta-analysis. There's several meta-analysis, including our first study on risk factors of dementia, which I published from India, following which there was several studies which looked at various risk factors. What has been found is that 40% of dementia can be prevented. So what can be prevented, we must act on right now. So what is it that can be prevented? And you see it here. Elderly with hearing loss, get it corrected. Prevent traumatic brain injuries. Don't play games which involve hitting something with your head. Control hypertension. Reduce your alcohol. Reduce your weight. Stop smoking. Do not be depressed. Consult the psychiatrist at the earliest. Have good social interaction, which is a positive social interaction. Reduce physical inactivity. Reduce air pollution, which we have no control over, especially when I come from Delhi, and reduce diabetes. So you have to work on all of these. If you can modify these 12 risk factors, the chance of any one of us sitting in this hall developing cognitive decline will reduce by 40%. It is imminently possible. What are the next potential therapies? Of course, many on the anvil, intranasal vaccine, antibody treatments further, oxygen therapy, stem cell therapy, still stimulation therapies, whether it's by putting intracranial electrodes into the hippocampus, or whether it's by wearing brain zapping helmets, or TMS therapy. These are all on the anvil. But till such a time that we get a cure for Alzheimer's, it is essential that we work on mobilizing our own government. It's very important that we have our patient presentation and care pathways in place, our assessment tools in place, our communication strategies in place, treatments in place, and management and follow-up. So this is part of the report, which is the patient pathway for mild cognitive impairment and Alzheimer's disease in Asia, which I was a part of all these countries to investigate what are the loopholes through which, or the gaps through which patients fall in terms of their management, diagnosis, and further counseling of our patients. We have to have a system readiness approach. It hasn't to be a me approach or my approach, a Dignity Foundation approach, or ARDSI approach. It has to be a systematic approach, of course, spearheaded by ARDSI. A prevention plan has to be in place, an early detection plan has to be in place, a therapy plan of making expensive therapies inexpensive, and a team of caregivers who are trained to look after this problem. With this, I'd like to end my talk, and if there are any questions, I can take them. Thank you.
Thank you very much, ma'am. We'll be having the question and answer session at the end of this segment. I now invite our second speaker for today, Dr. Kumawat sir. As we all know him, he's the mental health legal expert. Out of the various positions, prestigious positions that he has held, he has served as a superintendent at Regional Mental Hospital in Thane and as a member of Anti-Narcotic Authority of Maharashtra. I welcome sir for the next talk.
So, yeah, blood biomarkers are almost there. The plasma tau, 181 and 217. And the amyloid, the tau is much more reliable. So it's almost there. I think that's the next step which is going to be there, because there's enough research now. Of course, we do not have a standardized level in our population, and currently we are doing the plasma tau analysis for our population. So I think in the next year we should be able to have reliable plasma biomarker which can obviate the need for a CSF, which is so difficult to do in an elderly person.
Ma'am, if I may, I have a question. Ma'am, what is your take on the current drugs available for the MCI? Do they work, and how much should we depend on them to prevent dementia?
So the trials which have been done of donepezil and acetylcholinesterase inhibitors have not yielded positive results for MCI. So they are not advocated. However, if you have an MCI person who has the established biomarkers which are there in the CSF, and you have the access and the means to afford the monoclonal antibodies, then they have been tried in the MCI early AD population with reversing the amyloid beta deposits, etc. So as of now, they're very expensive. As I showed, the cost is some 25,000 US dollars. So that's really very expensive for our patients. However, there are some who can afford it, and one patient of ours has got it from the US and taken it. They require regular monitoring because there is a chance of development of headaches, and when you do the MRI, there will be an edema which has set in. So it's not just like over the counter or something. You will need to be on regular follow-ups with regular neuroimaging. Yeah. No, not yet. It's it is the intranasal vaccine is still in clinical research. That's anyone's guess. We had a vaccine before, but that caused a severe reaction, so there were a few deaths, so it had to be stopped.
Good morning, ma'am. Just a follow-up question on monoclonal antibodies. So is this treatment like lifelong required for a patient, because the tendency to have those deposits of amyloid and tau, that tendency is there in the patient? You reverse it, then do you need to keep taking these injections all your life?
So the studies done so far have been done for like 54 weeks, So that's the longest we know. And we are not sure how long it has to be taken, so 54 weeks it is. Dr. Shah, who had come from the US, who's being giving the lecanemab quite frequently, he states that he just doesn't only give the monoclonal antibody. There is an intense intervention regime which starts, which includes your lifestyle, your diabetes, your blood pressure, your smoking. All that starts with this. And he says the combined result is much better than just giving the monoclonal antibodies. So I suppose if we give this for 54 weeks and by then the lifestyle has changed, maybe it will not be required further, but at least 54 weeks is what is required.
Yeah, I have just a comment which I am fond of making at the AIC and also at the ADI conferences, and that is that we are all very excited that there are monoclonals. But as far as developing countries are concerned, there is really no equity. We will not be able to afford this for the general public for many more years to come. Forget the cost. Detecting people early, you can see from the surveys that attitudes are really low. To pick up people, it will only be for the rich. It will only be for people who can really afford it. So for the majority of our population, it will not be possible. But what I think we should, the tree that we should bark up is actually the prevention tree. Because if you see the LASI data, you'll see that it's not 40%, it's 60% of dementia in India can be prevented by not just these 12 factors. There are many more factors, almost 15 or now almost 20 factors. We are not doing enough in terms of mass public education, mass awareness, mass early detection. We are not doing enough, and I think we should be barking up that tree, because the majority of us cannot afford. We have started doing PET amyloid, we have started doing in EMANS, we have started making kits. I think in AIMS they're doing tau. Blood biomarkers will soon be available in AIMS and in EMANS because SIMO platforms are up. But that is really, everybody cannot go to AIMS and EMANS. So I think we are barking up the wrong tree. It's all very exciting. And we are still only 2-3 years down the line to see what will really happen.
True. Absolutely. I couldn't agree more. But however, I would like to state here that change of behavior, change of patterns, which we are accustomed to, is much more difficult. And if this change can be ingrained right from education level, then it's easier. But if people have got used to sitting the whole day, and you tell them to even get up and walk, it's a huge task. But this is the way to go. I completely agree with you.
Well, good morning to all. Respected Chairperson, Dr. Tripathi, dignitaries present in the auditorium, my fellow mental health professionals, ladies and gentlemen. At the outset, let me thank ARDSI Chapter Pune for inviting me to speak on this topic of healthy aging. Dr. Matthews, you were right in saying so, that awareness and education, which can prevent, and that will be a more important thing as far as prevention of dementia is concerned, or awareness about dementia is concerned. As Dr. Agashe sir had said, that it's our emotional attachment with that patient, not only as a family member but as a caregiver, is more important in managing the dementia. It's not only the medicines that will help him. At the broad view, I will just give you the concept of healthy aging. I'll talk about the key considerations about it, a brief about healthy aging and active aging, some tips to older people about healthy aging. I will just touch on the India status, the status in the developing countries, and how we address the challenges which are faced by the developing countries. As per WHO, if you see, as we grow, it's only the age that matters, we say. Whether we are sick or not, whether we are on multiple pills or not, we are still taking the pills, medicines, etc., but working. We are doing our independent chorus. We are doing some kind of interaction in society. We are attached to the community. And we try to have a balanced diet as far as possible. We also do some measures that will maintain our mental health, physical health. And this particular thing, that is to be independent enough to enjoy active and fulfilling life, is what is called as healthy aging. As we see in this picture, this gentleman, if you see that he must have worked in the garden, which is an important hobby to do gardening. He must have done some cleaning over there, must have taken few steps on the tile, and then still has the strength to maybe slow with support climb the steps. And this is what is matter in maintaining our healthy aging. So what are the domains of functional ability? We must move around, be in touch with community in such a way that we maintain the relationship, build up the relationship, meet our basic needs. We do our independent, whatever things which are required on our own. We must learn, grow, and make decision. And with our wisdom as a senior citizen, contribute to the various causes of society. Resilience. We may fall sick, we may get some disability, we may have some financial challenges, we may have some legal matters pending in court of law. However, we still do it reflect on our psyche and health, and we continue working in a healthy manner. To see what is active aging and healthy aging. Actually speaking, there is no gross difference. Active aging is a broader concept which encompasses not only positive subjective well-being. It's a good physical, social, and mental health, but also involvement in one's family, the friend circle or peer group, and community throughout the aging process. So it's not only that it starts at particular age or so. And healthy aging, like active aging, it also emphasizes the need for action across all multiple sectors or domains of our life and enables older people to remain a resource person. What is important is the resourceful person to their families, communities, and economies. So what are the key considerations of healthy aging? As Dr. Mohan Agashe sir was talking about the diversity, no two older people are equal. Everybody has a different kind of a physical structure, different type of background, different type of environment and financial situation. And thus, that is how they grow. And in this challenging or in a comfortable positions, they grow, and still they have similar kind of issues or challenges, or may have different issues and challenges. So this diversity is very important as we grow. Similarly, inequity. There are marginalized people, there are vulnerable people, and this is with their marginality, all vulnerability, they are still living. They may have some deformities, they may have some financial strictures, but still they have their ability to continue living. And that's why these are the two main considerations when we take about active aging. So let us see what are the characteristics of these people. While we grow, what are our characteristics that decide our health? There are certain age-related trends. Across the lifespan, there are certain changes which are taking place in our body, both by physical structures, by hormonal issues, and even the sexual development, and then the sexual recession after particular age. Health behaviors, our lifestyle, that matters the most, and of course the physiological changes which takes place. Now, all this is happening throughout life, but there are certain risk factors also there. We may get some diseases, some are acute, some are long-standing. We may get certain injuries, which may make us disabled for a long time. The homeostatic changes across the various events in body and in our environment. The geriatric syndromes which we face as a part of our growing. So, when we see at the core, it is the genetic overlay or the genetic burden which we carry, and at the genetic center, we have our personal characteristics. These personal characteristics are more intrinsic into our personality, our behavior, as a result of our personality. So it's the genetic, we as an individual, the way we grow, and the environment around, that matters the most. This environment, so there may be age-related issues, there may be health-related behaviors of ours, there will be physiological changes and risk factors that I mentioned, diseases and injuries, changes of homeostasis, and of course the various genetic syndrome. All these genetics and epigenetic factors affect us while we are growing. Genetically, hereditarily, if you see from the hereditary point of view, almost 25% that will decide that age of death if everything goes smoothly. There are certain communities, there are certain really ethnic people, they have a tendency to grow for longer time and they die at a later age. Longevity locus, it is also genetically decided. On chromosome number 3, there are certain genes also which has been identified. They are responsible for longevity. So it's a basically combination of genes, we as a person and the environment that decides whether we will age for longer time or not, apart from our personal life. So there are these personal characters, some of which are fixed, some of which are mobile. The fixed characters is the age. There is a certain age where we are highest mobility. After a certain age, maybe what is called as retirement, we tend to be more sedentary. We tend to forget that we still need to continue at least activity, if not work. Then the gender, the way the position is given towards individual gender in society, the way the particular position which is expected in particular society, that also makes important effect. The ethnicity, and that will decide again the longevity. Mobility, education, more higher position, more executive position, you tend to become less active and the life is more sedentary. Gender, again I was talking about the position in society. And wealth, of course. I did not say wealth goes more with the sedentary behavior. There are certain geriatric syndromes which we, across our life, when we grow, we get across because of our lifestyle. And there are multiple systems which also simultaneously are growing. So along with our age, we get that package of multiple elements like which are long-standing, what we call as comorbid illnesses like diabetes, blood pressure, it may be arthritis, etc. So how do we achieve healthy aging? First important thing is we must have a regular health assessment and monitoring. We must have proper nutrition or what is called as balanced diet. There has to be some physical activity. We heard from earlier speaker about vices cessation, whether it is tobacco that is in various forms or alcohol, etc. Comorbid control, we have multiple illnesses. We try to see to it that whatever is within our limit about taking care of them, we must do that. Mental health, it is very essential that we must have measures to see to it that our mental health remains in normal status. Age-appropriate vaccination. Sleep. Sleep is a very important aspect of old age, which is much affected and may lead to multiple or exaggerate multiple physical illnesses or may contribute for mental illnesses. Environmental control. There are certain things about our environment which are in our control, certain things which are unfortunately, if people are vulnerable, marginalized, are out of their control. Injury prevention. There are certain challenges in various systems which we get, particularly the skeletal-muscular system, then our sitting position, etc. And all these things, whether there are gadgets to be used, please don't hesitate to use it so that we can prevent these injuries. And of course, the public health and policies. So let us see about how we go for clinical assessment. Clinical the domains of clinical assessment are physical health, mental health, the socio-economic status of that particular individual. That it will also be important contribution in deciding our plan of action. And the functional ability, that is independence, whether he is living independently, performing his activities independently, or he needs assistance. Accordingly, our assessment and thereafter the advice and treatment will depend. Most important is isolation and loneliness, which is a part of this particular age. May people retire after particular age from some organization. After coming into the society where they start living on a day-to-day basis, throughout the day, they hesitate to interact with people, interact with community. So this is very important that they must find means and ways where they can communicate either with relatives, friends, or make some new friends, new groups, etc. Prevent social isolation and loneliness, because if you don't do this, it will be very distressing feeling of being alone and lonely, separated from the society. It is the lack of social contacts and having few people to interact that leads to all these things. This is also leads to multiple conditions like depression, heart diseases, or even what we have seen in COVID times, the social isolation which was compulsorily put up because of the situation then had exaggerated dementia-like illnesses, or had put people into cognitive decline and led into dementia-like illnesses. It has also put us into depression then in COVID times. So how we avoid it? Interact with play, which are age-appropriate play, card games, chess, carom board, all these things, even words, puzzles, etc. This will not only help us in kind of developing camaraderie, but also it will help us in some kind of cognitive exercises. We must have a proper schedule of the day. Don't just go and start your day or week or month, etc. We must have a proper schedule, plan our schedule, and accordingly do our monthly, weekly, or daily course. Encourage people to develop interest, those who are senior citizens. They may not be aware what to do, so it may be music, it may be learning new language, it may be learning the new technology, or updating their knowledge in whatever field they are. That will help them to cognitively maintain their health. Search for various elder care helplines. This will be very important in case of any kind of emergency. They are in touch with this, they are fed in their mobile contacts so that they can immediately take help. Even for this issue, there are legal aids also available, so that also should be accessible to them. Find additional tips to help your loved ones stay socially connected. This should be very important because this kind of interaction helps them also emotionally maintain healthy. Exercise, it has been mentioned much about this. Various exercises are there which are age appropriate. It may be Zumba, it may be yoga, it may be aerobics, it may be balance training, etc. Even a brisk walk is also important. But exercise is a very important part of this. And not only it will help your health, muscle, it will help developing a balancing also, and more importantly, cognitively also it will be helpful. If you do regular exercise, you feel tired, you get a good sleep also. You don't have to go for any sedative medicines. So again, when you plan a schedule, similarly, you must have a schedule when to do exercise, when to go for a walk. Now, it need not be necessary that you should wake up at 5 o'clock, 6 o'clock. You can do the same exercise in the evenings also. Even simple exercises, like I remember when you recover from bypass post, the first thing the physiotherapist teaches you to do exercises is a mineral water, which is generally available at homes, empty mineral bottles. So he just asks you to do muscle strengthening by those mineral bottles. You can do many exercises which are so handy and can be done at home. You don't need expensive equipments. You don't need to go out to any gym for that. And most important is necessary whatever dresses which are required for such exercises must be made available by the caregivers to them so that they find it comfortable doing it. The experts say that around about 150 minutes of walk, which is necessary for maintaining healthy, physically healthy. So this is most important for us. So encourage all the older adults in your life to exercise regularly. There are certain some encouragement which is given by suggestions for daily movement of these people. At our home, we have seen that for simple things, we ask our support staff to get those things. It is important that if we get up at that time and do certain things in home only, this will definitely help our own exercises rather than making us sedentary. Regular health checkup. Now, this is very important both for the patient and the caregiver in the family, that they should see to it that a patient has undergone a regular health checkup. So this includes the appointments of the doctor, scheduling the appointments of the doctor, giving the patient tips for what are the questions to be asked to the doctor, arranging their medicines, ensure that the medicines are taken regularly, and if the patient is finding it difficult, arrange them in such a way that the patient makes it, understands it, which medicine to be taken at what time. This is very important because these health checkups will keep our patient healthy, or at least will minimize the difficulty, challenges, or the morbidity because of the various physical illnesses. Encourage healthy diet. Now, I did not talk about encouraging healthy diet at old age. It has to be across our lifespan. But in particularly at old age, it is more important. Apart from doing our exercise, it not only adds to our strength of muscles and bones, it also, if you add fruits and some healthy proteins to it, it will also help us in maintaining less of a fat. And it lowers risk of multiple physical ailments, not only cardiac and others, but also depression. Calorie restriction is very important. Almost 20% calorie restriction at this age and this stage of life is very important to have healthy aging. Vices. Maybe I mentioned about tobacco, alcohol, etc. Dr. Manjari has been kind enough to ask you to reduce alcohol rather than stop alcohol. But it's again an individual choice if you know when to stop and when to reduce. So be very careful about it. Sleep. Sleep leads to lots of problems if you don't have proper sleep. In old age, otherwise also, you have early night falling, difficulty in falling sleep, you have difficulty in maintaining sleep, and you may arise early. As I mentioned that if you do regular exercise, you will get tired and get a good sleep. But fortunately, with the advent of technology, we have monitors that whether the patient is sleeping regularly or not. If you find that you are not sleeping properly, don't hesitate to take help. Don't hesitate to take medicines. I sometimes wonder in my clinic when the patient at 74 asks me, doctor, क्या ये जिंदगी भर लेना पड़ेगा, the pills? I mean, I just keep looking at him and I say yes, because we don't know what is our life. Till end, we need to live quality life. So जिंदगी भर लेने में कोई अर्ज नहीं है. Nobody gets addicted at that particular age and stage of life. Mental health and stress. We are fortunately blessed enough to have lots of traditional things like meditation which can help us. We must do stress management, time management, which can help our mental health. And also the various supports from the family members also can help patient maintain mental health. Now, the challenges we face at this age are because of the bereavement, separation, divorce, etc. And it has been found that such people have lots of mental health issues. So special care needs to be taken of these people. Abuse of elderly. In fact, this is a kind of a thing which is not much reported, but the prevalence is very high. It's like a peak of iceberg phenomena. And it's very commonly seen that abuse of elderly within the families, forget in the society, is done regularly. There are rights violations, etc. Then, of course, social isolation and loneliness also can lead to depression and stress. Environment, I mentioned that it is not necessary that environment is within your control, but sometimes because of the financial, socio-economic status, that the unhealthy environment can lead to multiple, not only physical, but mental health issues also. So, if more and more clean and healthy environment, it is good for healthy aging. We need to have those public health and policies in tune with our physical health. How much time? 5 minutes, yeah. In tune with our concept of healthy aging. So we must have a financial security, housing security, personal security. As I talked about personal security, there are lots of robberies, deaths, etc., thefts, etc., which are happening at elderly people as they are soft targets. There must be mapping, which more of a proactive mapping of elderly people for disaster management planning. Yes, foster cares must be there, mobility, and that mobility needs to be done smoothly. We find that mobility for senior citizens across the city is not so much friendly. Yes, building and maintaining relationship, which also will help them. Ability to contribute, take the wisdom of these people, collect them and take maximum help from these people towards any social cause. If you see the geriatric population, it has been going by leaps and bounds by almost 2000 in 7.7%, 2000 it was 7.7%, it is in 25, 13.3% which has been projected, and out of which 71% lies in the developing countries. As far as India is concerned, for India it is in 2003 it is 70 million, while it is expected to be 177 million in 2025. 40% lies below poverty line, 73% of which is illiterate population, which is a big challenge. India faces several challenges and opportunities in this area of health. Growing elderly population, aged 60 and above, is projected to reach 300 million by 2030. 10% population of which is elderly. Life expectancy is going up, and similarly the elderly population and health-related issues. Chronic diseases are taking toll of the elderly people, and of course simultaneously mental health issues. There are various policies and care schemes projected by the central government of India for the same. If you see the India health sector response to this, there are national policy for senior citizens, health insurance schemes, geriatric care models, etc. However, the role of NGOs, I find it more focused in the metro cities and the major cities as against in rural zone. Thus, we have inadequate geriatric training. Policy remains on paper. Implementation is lacking at grassroots level. Lack of awareness and education. There are absolutely need for community-based programs or daycare centers, etc. Frequent right violation is a major challenge. We have now threat of digital and cyber mafias on the senior citizens, which are soft targets. And in short, the government, community, and healthcare providers all should come together, plan action for senior citizens. At the end, the only real limitation on your ability is the level of your desire. If you desire how bad you want it to be. Thank you very much.
I would like to invite our next speaker, Mrs. Meera Pattabhiraman, ma'am. Ma'am is the Vice Chair of the Alzheimer's Disease International and President Emeritus of ARDSI. She works extensively in the field of dementia, especially when it comes to research. Ma'am is going to talk about global perspectives of dementia and importance of national plans.
A little bit way behind schedule, so do I still get my half hour, or I don't want to keep all the participants between lunch and say, okay, come on, hurry up with this. So I'll try to do a good job and cover whatever is necessary and still, see that I don't keep you away from lunch. So first, I'd like to congratulate the Pune chapter and Ronnie for organizing this conference and for inviting me. And Chaitanya Institute is also celebrating their Silver Jubilee. So my hearty congratulations to the Chaitanya group on this milestone achievement. And regards ARDSI, as I told in the morning, this is the first time that we are meeting since the pandemic. It's a golden opportunity for members of ARDSI to meet in person, because we found that it's always better to see in person. And this is the first time we are meeting under our new and dynamic chair, Mrs. Renu Vora. So this is about ADI. Paula has already presented this slide, but I will tell you that we are celebrating our 40th anniversary. In fact, we had a small birthday celebration at our international conference in Krakow in Poland at the end of May. And regarding ARDSI, we are the first Afro-Asian country to become a full-fledged member of ADI. This happened way back in 1993. And just 1 year after ARDSI was officially registered as an organization. So full credit for this should go to our founder, Dr. Jacob Roy. And ARDSI is not only an important member of ADI, we are also an important member of the Asia Pacific Regional Office of ADI, which was formed about a decade ago to cater to the needs and requirements of the associations in our region, because we have similar cultural and social heritage. And the Asia Pacific Regional Office is working closely with CRO. And we have found from experience that in those countries where the WHO office and the ARDSI or the ADI associations are working collaboratively, the advocacy measures are paying off. So this is what we need to do, is work along with WHO and other related organizations. So you will see from the expanse of red here that we are represented all across the globe. You can see a lot. These are the ones in red are where we have all the associations. But one continent where you see we are mostly underrepresented is the African continent. We have very few associations because awareness is very low there. Stigma and discrimination is very high. We had a STRIDE research study which showed in that they felt that dementia is due to witchcraft. So that is the level to which stigma and lack of awareness is present in the African continent. And the ones that you see in gray, these are the areas where we are trying to build associations. And we have a process for this. What we do is we have a membership development program. So we identify groups who are working in this area, and they have to go through the membership development program run by ADI. And after successful completion of the same, they become recognized as an official member of ADI. So dementia is like a hidden time bomb. As Paula said, every 3 seconds, there's a case with dementia. We are not just plus 55 million. We are close to 60 million people with dementia in the world. And 1.3 trillion is necessary to take care of persons with dementia. We're the 7th leading cause of death and 25th in the highest disability-adjusted life years. And do you know how much time is required? 103 billion hours of informal care is necessary right across the globe. And this is equivalent to 67 million full-time workers. This is the amount of energy that is required to take care of persons with dementia. And 70% of the care is from informal carers, and who they comprise of? Female population, because it's either the wives or the daughters-in-law. And 50% of the care goes on informal care. But this is largely under-recognized. We did a stride research study on informal care. It is under-recognized, but it cuts into the budget of the families. So this was published by WHO's Global Health Observatory, and we found that that particular year, COVID came second after heart disease, but dementia under NCDs is the 5th leading cause of death, and overall it is 7th leading cause. And the year it was 1.8 million people globally who succumbed to Alzheimer's or other forms of dementia. And this one reason for this is that a lot of people who were there in long-term care centers in the Western countries, they died in those centers. So ADI has been working with WHO for several years now. We've been advocating with them for more measures for persons living with dementia, and this has paid rich benefit for us. In the year 2012, they published Dementia, a Public Health Priority. This remains the tagline for us for all these years. This is a starting point for any national plan and for us to advocate with the governments. And then after that, we had the publication of the report on aging and health. This again covered dementia extensively. Then in 2015, we had the regional plan for Americas. And during this time, we had a lot of countries in America launch their national plans. And finally, we had the biggest success was the Global Action Plan on Dementia in May of 2017 at Geneva. And our health minister at that time, Sri Nadda, was present there, and he endorsed this Global Action Plan. So what does this Global Action Plan signify? They have set 7 action areas under which governments should take action so that people with dementia are helped. And the starting point, of course, is the governments to recognize dementia as a public health priority. And awareness across the globe is very low. So what we need to do is have more dementia-friendly communities and societies so that the stigma and discrimination is reduced. And then, as Dr. Matthew Burgess said, risk reduction and prevention is very important because otherwise the numbers are going to get escalated. Dementia timely diagnosis, because when timely diagnosis does not happen, whatever medication is available, it is not going to be helpful. So what we need is, and 50% of the cases with dementia don't get a diagnosis. They think it is just a normal part of aging. And when diagnosis doesn't happen, the person with dementia is not helped, neither are the carers, because they don't get any support. Because they think he's a normal person, there's nothing wrong with him. So what kind of support does a carer get? Then we need to have dementia information systems and dementia research and innovation. And what is critical is that by 2025, we said that all countries should have dementia national plans. So what exactly does a dementia national plan signify? It is for the government to come with a policy change, or where there is no policy at all, we need to have a policy which is aimed at enhancing prevention and then to have timely diagnosis, treatment, and care for persons with dementia. But how can this happen? For this, we need to have collaborative effort of the health and social sector. So this essentially serves as a guideline for us which set targets for diagnosis, care, training, advocacy, everything. We need to have targets, and more importantly, we need to have resources to achieve these targets. And then we have to have annual evaluation to see whether they are meeting these targets. So why do we need national plans? This I go back to WHO again. Why do we need? Because only when first is, of course, diagnosis. Without diagnosis, there is no post-diagnostic support. And so both the person with dementia and the caregivers do not get any help. I have heard many caregivers tell me, if only we had known that this person had a problem, we just thought it was normal part of aging. So we did not give the proper support. Especially, we have repetition and, forgetting, short-term memory loss. There's been a lot of discord among family members because of lack of understanding. So timely diagnosis is important, and awareness and combating stigma is equally important. As we saw from our Attitudes to Stigma report, which Paula spoke about, over 65% of healthcare professionals don't know that dementia is a disease. They think it is a normal part of aging. So definitely we need more awareness, training, and education for healthcare professionals. There's no doubt about prevention and risk reduction. We spoke about healthy aging, changing in lifestyles. That is very critical, especially in countries like, heavily populated countries like India, China, Indonesia, Brazil, all these countries. Till we get the elusive cure for dementia, we need to concentrate on risk reduction and prevention. Then it is not possible for civil societies or for any other organization to keep track of the prevalence and incidence of dementia. What we need is for the government, and one way they can do this is to have this as part of the census that we conduct periodically. And finally, we had what are our preparedness for drug breakthrough. As Dr. Manjari said, a few clinical trials are over, a couple of drugs are out in the market. We said it was running into lakhs for a treatment in India. Prohibitively expensive for persons in lower and middle income countries. They are not going to reach us, and nobody is going to benefit, and the bulk of persons with dementia reside in lower and middle income countries. So it's only up to the government to see how these drugs are made affordable and accessible for persons in our countries. Not only India, all middle income countries. So these are the countries where we have dementia national plans. But this can be quite misleading. You will see a lot of red, but actually there are only 39 countries with dementia plans. The bulk of Africa, Latin America, they don't have any plans at all. And the ones in gray are the ones where there is some progress. Plans and strategies are being in the development stages for a national plan. So the target, according to WHO's Global Action Plan, is that we need to have 146 national plans by the year 2025. Right now, we are in 2024, and we have only 39 plans. We are way short of our target. Earlier in 2018, we had about 24 plans. Since then, we have added just 15 plans. And for the last 3 years, we are stagnating at 39 plans. So we have a lot to go before we reach our target of 146 plans we just have 1 year left. So that is why ADI is advocating with WHO to have extension of the plans. Here you can see the number of region-wise the plans that we have. The European region is the highest with 20 plans, and then followed by US, and then in Africa there are no plans. So we are now targeting areas where there are no plans to come up with more plans. As I told you, we are seriously advocating with WHO for an extension, and we are in discussion with all the member states of WHO. We have reconnected with the executive board members because they are having an executive board meeting of WHO in February next year. So we are urging all these members, bring up this discussion on dementia and have an extension of the Global Action Plan. And we are keeping our fingers crossed this will happen so that we can put our advocacy measures again on the governments to get our plans. So this is the spotlight in our region. So you can see there are only 2 plans in Southeast Asia, and 3 member countries are developing plans. Unfortunately, some countries have announced plans, but there are no funding for that. So it remains a plan only on paper. The real benefit does not reach persons with dementia. But this is only according to WHO. But there are few countries who are not member of WHO, but they are still doing very good work. One country I can tell you is Taiwan. So the Taiwanese Dementia Association is doing great work. They have full support from the government, whether it is awareness, training, running services, they are doing excellent work. So apart from that, WHO member states, there are other states who are doing it. So this is in India. Here we have 8.8 million people with dementia. It's expected to rise to 16 million people by 2036. And you can see that it is more prevalent among females than among males. We have 9% for females compared to 5.8 for males. And when you look at the urban-rural divide, it is more prevalent in rural than in urban areas. The percentage is 8.4 for rural compared to urban, which is 5.3. Regarding ARDSI's advocacy measures, we are doing a lot of advocacy measures for the past 15 years. The starting point was when we published the Dementia India report way back in 2010. We have 2 of the authors of the Dementia India report with us today, Dr. Matthew Verghese and Dr. Amit Dias. This was the first comprehensive report on all aspects of dementia: prevalence, cause, projections, what are the facilities available, the huge gap that exists, and recommendations to the government. And after that, taking a cue from WHO's Global Action Plan, we published the Dementia India Strategy Report in 2018. This was done after we had a series of consultative meetings in India in the 4 regions, and then we published this report. This was handed over to the then Health Minister, Sri Nadda, at the National Conference of ARDSI, which was held in Bangalore. But next year, the health portfolio was changed, and Dr. Harshvardhan became the health minister. So we again met him in Delhi. We handed over a copy of this report along with a request for a national plan. That was in January. Then COVID struck us. Dementia got pushed to the back burner. After that, country went into election mode, and still there was no progress. But this is the right time for us to restart, to reboot our efforts for advocacy. But this requires, we need collaboration from multiple sectors: medical, social, policy, and public health. We all have to join together to see that more can be done for persons with dementia. So this is what the Dementia India Strategy Report entails. I'm not going into the details because tomorrow our Executive Director Narendra will be presenting this in great detail. What I'd like to say is that we are trying to leverage the presence of ARDSI and other like-minded associations to get some realistic targets, whether it is awareness or how we can get prevention under NCDs, or how we can get support for caregivers using these civil society, and how we have an information system by setting up of a national dementia strategy, a registry. Even though we have not had success at the national level, one state where we had success is in the state of Kerala, where in the year 2014, we had the Kerala State Initiative on Dementia. This is the first public-private partnership, an ideal partnership to be replicated in other states. I've heard that 2 or 3 states are trying to get something on these lines to be started in their states. So what this entails is to have massive awareness. And we had 2 statewide campaigns where an ARDSI team went through all the districts of Kerala, raised massive awareness. We have 2 centers, one full-time center and one daycare center, totally free for the underprivileged. This is going on. We want to have more centers like this. Then we have said we will have memory clinics attached to government hospitals. Unfortunately, this has not taken off. And we have done massive training of health workers, whether it is the ASHA workers or the Anganwadi workers. We have done a lot of training over the last 10 years, and I can confidently tell you that Kerala is the most friendly and dementia literate state in all of India. The latest advocacy we have done recently was when India took over the G20 presidency. So we wanted to get dementia on the agenda, but we were told that the agenda was set at the concluding meeting of G20, which happened in Indonesia, so we could not bring dementia into the agenda of G20. But what best we could do was that we also had the C20 summit in Jaipur, the civil society summit. So we got an invitation for D.Y. Soharia, who's the regional director of the Asia Pacific Regional Office, and also Narendra, to attend this meeting at Jaipur. And these recommendations were given to the C20 group, to the G20. And we got dementia mentioned under two categories, the disabilities group and women's empowerment under healthier aging. So this is our latest advocacy that was happened last year. World Alzheimer's Month, we have had a very vibrant World Alzheimer's Month. We have a group, an ARDSI group, where we have so many postings of all that is happening, memory walks, lighting up of monumental buildings. We had TV shows, we had radio shows, music therapy. We had one of us who turned into a poet and wrote an excellent poem about, risk reduction. He used the Lancet committee's, various risk reduction, and it was an excellent poem. So, we have done very imaginative ways of observing. The reason why I'm saying this, we are not celebrating, we are observing to create more awareness about dementia. So we have had a very vibrant World Alzheimer's Month, and I would like you to continue posting your, we can even post about this conference because this is part of World Alzheimer's Month, and use the hashtag time to act on dementia, time to act on Alzheimer's. And this is the World Alzheimer's Report, Attitudes to Dementia. This is a very voluminous report, but very useful to show how much of stigma and discrimination still exists and how much more needs to be done in terms of creating awareness. And you can scan this, or you can go to the ADI website to get a copy of this report. In conclusion, on behalf of ADI and ARDSI, I'd like to urge the government, both of India and the state governments, to come up with plans to help improve the lives of persons with dementia and their family caregivers. What we need is a robust policy and strategy to address the various needs: timely diagnosis, support, prevention, research, setting up of services. And this has to be done in various regions. We can do it at the state level and at the national level. And for that, let us work together to make this come true. So these are the contact details of ADI. And I thank you all for your patient listening. I think I've kept up my time.
Thank you, ma'am. We'll be taking questions for the speakers now. Can I request the team to please pass the mic in the audience?
Good afternoon, everyone. I have an important question to ask to all the faculty members. I understand this conference is basically on dementia, and we are understanding the importance too. But compared to other mental health disorders and other physical illnesses, how will you prioritize or advocate working on dementia compared to these problems? And when we make a policy, are there any simple solution or practical solutions where we can make it easily implementable? And yeah, that's it. because it's still the 25th, it has the highest disability as adjusted life years. So it's 25th and but how will you prioritize it compared to, like, if you want to really focus on making a policy on dementia?
Yeah. Now can you hear me?
Yes.
Yeah. So it's not easy to only focus as a disability. It comes under disability. Okay. But it has a whole range of things. We cannot handle only disability because we have to start with early diagnosis. That is a starting point. Awareness, because people don't even go to the doctor to see it is a problem. So it is a combination of several things, and then only we can deal with disability adjusted
No,
life years.
compared to other problems of the elderly, how will you prioritize this problem or advocate for this problem?
Because dementia remains an under-recognized thing. You see, if you take anything else, if you take cancer, heart disease, everything, it is there out in the open. This is still not spoken about because of the taboo. People don't want to talk. Behavioral problems are there. So even if somebody has, several eminent persons have had dementia, but they won't talk about it because there's a taboo attached to this. So that is why we are trying to bring it out from that, bring more awareness to that, and then we will address the disability aspect of it.
And how will you make sure that it is easily implementable, the policy?
That is $1 million question because,
Collaborative thing between
Eh,
government,
yeah.
and the caregiver or the people
Yes, you want to add on?
It's basically a collaborative effort, not only from government, which come up with policies. It's also by the help of NGOs and in general the community also, the caregivers, etc. What I understand is, again coming to the first part of your question, in general mental health is not a priority by the government. Honestly speaking, it's still on paper. Dementia is a part of it. So first mental health should come on the priority. After mental health, dementia is one of the part of it. If you have a healthy mental health lifestyle, I repeat, healthy mental health lifestyle, healthy living becomes very easy.
Just to add to my friend here, see, the numbers stand in our favor, just for your information. The numbers stand in our favor because we have 8.9 million people affected. If you take any other disease collectively, like for example, HIV/AIDS, what is the number nationally? It is only 2.5 million. Tuberculosis, 2.8 million. But we have 8.9 million people. So that stands as an advantage for us to advocate. But once again, see, when I take tuberculosis, when I take HIV/AIDS, they comprise a productive population. Okay? Here, we are talking about who are considered to be a spent force. Okay? We need to very creatively put this up, and ARDSI has been doing its bit, and we want all state governments and people here to join this cause and propagate this as much as they could so that people find it. Because as of now, dementia in any form is facing a big syndrome, which I passionately, which I degeneratively or what we negatively say it as not in my backyard syndrome. Okay? Whenever we talk about dementia, people say, oh, it is not happening to me. Unless and until somebody is personally affected, people don't take it seriously. So we need to be very concerned, because spent force, when we think, they are not spent force. Think about the wisdom that they are going to give to us. So if you value that wisdom, so we can very easily advocate. Thank you.
Do we have further questions?
As the doctor had said, that about preclinical stages of dementia, probably we are all there. We are all in the preclinical stage. And, so this is where I think the lifestyle changes, as some of these panelists have said, would be very helpful. So I think, you know, because biomarkers going for these things are going to be very expensive. So let's all think that we are in the pre-dementia stage and work towards it. Thank you.
Thank you, ma'am. I request our chairperson, Dr. Vatve, to kindly felicitate the speakers. Manjari, ma'am. I request Dr. Rohan sir to please felicitate Kumawat sir. Meera ma'am. I request Dr. Ronnie sir to please give a token of appreciation to both our chairperson and the co-chair for this session. Thank you. Before we break for lunch, Dr. Vijay Kalbande, Assistant Director of Health Services, wants to give a quick set of instructions.
Doctor, psychiatrist, social worker should stay here, so that you should see that how the program is arranged. And dementia is a problem which is major, and you are working in the field, and you should implement the dementia problem also very well. Thank you.
We break for lunch. The next session begins in this very hall, sharp at 1:30. Thank you, everybody.
Kindly allow me to welcome our chairperson, Brigadier Dr. S. Sudarshanan. He is a graduate and postgraduate of prestigious Armed Forces Medical College. He has served in various field and high altitude areas and as a psychiatrist in important military hospitals, including Army Hospital, Command Hospital. He was posted as professor and head at AFMC and commanded Armed Forces Medical Depot. He has retired in 2006, and then he served as a professor and head at Shubharti Medical College, Meerut, and at Asian Institute of Medical Science at Malaysia. Presently, he is a consultant at Chaitanya and Ruby Hall, Banori, Pune. Along with him, we have a co-chair, Dr. Swapnil Deshmukh. Let's welcome Dr. Swapnil Deshmukh, sir. He is a private psychiatrist at Pune. He is also director of Manovardhan Rehabilitation Center. He is a director at Satyak Dementia Care Center, and he has been past president, Indian Psychiatric Society, Pune branch. I'll now call upon our first speaker for this session. Let's welcome Dr. Shima Ninan, She will be speaking on overview of dementia. A brief introduction about Dr. Shiva. She is a distinguished psychiatrist with extensive experience in old age psychiatry. She obtained her FRC Psych from Royal College of Psychiatrists, London in 2022, and her CCT in old age psychiatry from General Medical Council, UK in 2017. With a medical degree from the University of Mysore, India, and her MRC Psych from Royal College of Psychiatrists, London, Dr. Neena has developed a robust academic and clinical career. Currently, she serves as an assistant professor and senior consultant at Telemanas, that is at Kozhikode, Kerala, IMHANS. Dr. Neena is also an active reviewer for prestigious journals, including Asian Journal of Psychiatry and Kerala Journal of Psychiatry. Her research focuses on dementia, psychiatric disorders in the elderly, and therapeutic interventions. She has also contributed significantly to the field with numerous publications in leading journals, including studies on thyroid status in Down syndrome, cardiac conduction changes related to olanzapine, and rare cases of young onset dementia. Dr. Neena is currently engaged in ongoing research, including the Malayalam adaptation of the scale ADAS COG and exploring music therapy as an intervention in dementia. I'll now call upon Dr. Shiva to come.
Excuse me. May I have a word, please? May I take this opportunity? Good afternoon, ladies and gentlemen. I'm Brigadier Sudarshanan. May I take this opportunity to thank ARDSI and Dr. Ronnie and his team for giving me this honor and privilege to chair this session. And in fact, it's the first time I ever came to know about this premier institution, this organization, which is doing fantastic service from whatever I've heard, and I've read a lot about it now. I'm really proud to be associated with this particular conference. Thank you. Yeah.
Good afternoon, everyone. Thank you so much at the outset to Chaitanya Institute, Dr. Ronnie, who has organized this ARDSICON and invited me to be here as a speaker. I feel very privileged to be here. So without further ado, I now move on to my topic. So today's outline would be on an overview of dementia. Before that, I would like to say I work as a geriatric psychiatrist in IMHANS, and that is my institute in Calicut. I'm also part of the Telemanas team, which is a tele-mental health national program. I'm not sure how many of you have heard of that. It's a free service. It's a 24-hour service taken on by the counselors as a tier 1 service, and then goes on to the MHPs, so the Mental Health Professionals and Mentoring Institute. This was under the apex body NIMHANS and also coordinated by IIITB. It's a national telemental health program, a very useful number for anyone who's got any mental health related issues, any age group. So just to tell you that as well. So today's outline would be a current scenario with regards to the epidemiology in dementias. We're going to gently look at the reversible and irreversible causes of dementia, some common types we see, and some rare types. So one of our esteemed speakers already touched on healthy aging. So when we talk about aging, aging is a natural phenomenon with opportunities and challenges. Based on the 2011 Indian data, India has around 104 million older people above the age of 60 years. This constitutes 8.6% of the total population. And females outnumber males with regards to this. India has loads of policies, some of them being the National Policies on Older Persons 1999, the Maintenance and Welfare of Parents and Senior Citizens Act 2007, the National Policy for Senior Citizens 2011, which forms some of the legal framework for supporting our older adults. And there are ongoing policies, committees, frameworks which are ongoing. So I can speak for Kerala. We have a lot of healthy age committee. I think Renu ma'am is part of that, Meera ma'am is part of that. We're actively involved in getting the older adults, get the ball rolling really. And I have to say Kochi is possibly one of the first states to be attached with the WHO for the older adult friendly city. And I think one of the states in Kerala will follow suit very soon. So moving on to that, So this data is picked on from the World Population Prospects from 2019. So here, this is a population by broad age group, looking at the years 1950 to 2050. So this, if we look at this, the bottom bit here shows the age group of children up to the age of 14 years. The bit above that shows adults up to the age of 59 years. And the top bit is really those above the age of 60 years. So what this really says is that the aging index in 1950 was showing a percentage of 8.4 for those above the age of 65 years. So for every 100 children, and this was expected to become about 74.5 for every 100 children by 2050. So basically this is just a trend across all the aging indicators, signifying a rapid pace of aging in the country in the coming decades. This is a data map which we've got from the India Aging Report 23. So here we see the different states of India, and this is an estimated data projecting up to 2036. So if we look at the colors here, as the color grows, as you can call it gray, and as the gray color becomes darker, it shows the prevalence of older adults. So here we can see that in the northern states, it's specifically Punjab and Himachal Pradesh. At the bottom, we have Kerala, we have Tamil Nadu, Andhra Pradesh, and on the other side, we have West Bengal. So all of these states will have a higher prevalence of older adults by 2036. And by 2031, there is an estimated prevalence of older women being more than older men. So that's 1,078 compared to 1,000 males. The other graph is again a decadal growth or a comparison between the two populations. So between 1951 to 2031, we can see the green dotted line. This indicates the normal population. So we can see that from 1961 onwards, there's a general decline in the younger adult population. Whereas if you look at the red dotted line, it shows the older adults. And the older adults, although there's a decline up to 1991, 2001, there's a status quo. And then we can see that there is a gradual increase or progression in the population from then onwards up to now, or up to 2031, which is the prediction. So basically, life expectancy varies throughout India. It varies from 64.8 years in some states to as high as 75.1 years in some states. Kerala has life expectancy of 75.1 years. The next data is from the LASI. We all know that the major health surveys happening in India, one was the National Mental Health Survey from 2016. The other is the LASI study, which Matthew sir is very much a part of. So this is from the WAVE one, and gently really to say that this bit which talks about the aging index, which is the second last column, it refers to the number of persons who are 65 and above for every 100 children. And again there we can see that states like Goa, Kerala, Himachal Pradesh, Punjab are all on the higher side. So this is really just for us to be aware of what is happening within our country from a data perspective. So the studies say that the prevalence of mental illness among older adults may be higher than the reported figures because of stigma, and also because of the fact that there are not enough trained mental health professionals who are able to pick up this at an early state. And also the burden of mental illness is actually pervasive in nature, especially if there is a distressed socioeconomic condition and other factors. So this might not be an actual representation of the data. So the next data sheet is again from our LASI study. Here we can see that there is reports of Alzheimer's and related disorders. So if we look at those above the age of 60 years, as expected I suppose, we can see that there's a higher prevalence in that age group. There's a higher prevalence in the female age set, and also it is higher in the rural area. And also we talk about other neurological and psychiatric problems as well. So most of the common instruments that are used during clinical studies or research programs are usually some cognitive screening battery, which was used, developed in Hindi by Ganguly ma'am. I think she was one of the ex-professors of NIMHANS. And then we have the Hindi mental state examination, which is an adaptation of the mini mental state examination, which was also developed for this study and then later translated into many other languages. There are also instruments that are used to look at the activities of daily living, like the Everyday Ability Scale for India, which is the EASI. We use that as much in our clinics. And also the Instrumental Activities of Daily Living by Mathurnath, which I think which was talked on earlier. We also have the ICMR Neurocognitive Toolbox, the Mudra version, which we use in our memory clinics, the Malayalam version, which we use in our clinics as well. And this was actually based on the Addenbrook's cognitive evaluation and other cognitive tests. And we have the NIMHANS neuropsychological battery for the elderly, which we use in our memory clinics. Again, there is the normed for elders from 55 to 85 years. The Mudra is also used for those above 65 because there are some standardization issues, but Mudra and the NIMHANS battery, the common ones used in our memory clinics. So all of these instruments were developed and adapted based on education and cultural norms for use in the older population. And some other common tests or screen tools we use are the MOCA, which is the Montreal Cognitive Assessment Tool, which is a very easy tool to use. I think Dr. Manjari talked about it earlier on in the study. It takes just about 10 minutes and it is suitable for mild cognitive impairment. The other one is the Mini-Cog, which takes really just a few minutes, and it's used for screening dementia or major neurocognitive disorders. The RUDAS is another scale. It is also known as the Rowland's Universal Dementia Assessment Scale. It is actually used across all cultures, so it's cross-cultural, and you can use an interpreter and use this scale, especially if somebody's having some impairment like hearing deficits, if they're not very educated. This is a very useful tool. From a functional assessment point of view, we use the ESI for the Everyday Ability Scale for India. And it is useful to repeat these tests, just look at the progression or just to see if there is a decline, and it is really for our records as well, for an understanding of what is happening from a treatment point of view or from a management point of view. In addition to the tests, an assessment really involves taking a really good history from the person with the problem as well as the family or caregivers, looking at laboratory evaluation, which usually includes the usual blood screens, which you're all aware of. In some cases, we can also look at specific tests such as the VDRL, the HIV, ASR, the lumbar puncture, sometimes heavy metal screens, ceruloplasmin, for looking at any rare causes of dementia. Imaging, of course, which is very helpful and useful. A very detailed neuropsychology evaluation. We also think about gait and motor testing these days as well, because sometimes memory may not be the primary symptom. It might be gait difficulties or motor symptoms as well. And we also look at CSF markers, which Dr. Manjari has already touched upon. I'm just going to deviate slightly bit. So we, in our clinic, in our lab here in IMHANS, we have a neuroscience lab there. So we're having this study here where we're going to look at gait disorders associated with aging, associated with dementia, rather than just focusing on memory decline. So that's how things are progressing nowadays. Moving on to the next graph. So this is graph again from our studies, looking at age and education. So the first graph, we can see that there is an increase. So the red line represents women and the blue line represents men. There is an increase in dementia prevalence in the woman. And this is, so what they say is that the age-specific prevalence is higher in women. Also, those with no education seem to have a higher prevalence as compared to those with middle or more education. So that's a green line which shows those who have some education, and those with no education, the bottom top line there. The next one is really a map of India, which actually looks at the urban and rural. So the first one here on this side is the urban, and the other one is the rural picturization of the different states and union territories in India. It estimates the dementia prevalence. So the colors really, so green represents lower colors, and as it becomes more prominent or more towards red, it shows an increase in the prevalence of dementia. So I think we can, from this it shows that the highest prevalence, as we can see, is in Jammu and Kashmir, whereas the lowest prevalence is in Delhi. dementia prevalence is lowest in Delhi. So I think Renu ma'am will be quite happy to know that. So that's interesting, just to kind of understand why that may be the case as well. So the results really, what we find here is that the risk of dementia appears to be strongly related to age and education. And it's statistically, the odds ratio of demographics tends to be statistically insignificant. Most strikingly, the female sex is fairly modest and statistically insignificant, 1.2, suggesting that the large sex difference may be attributable to females being older and less educated. With this in mind, we will now move on to the dementia proper. So we don't actually call it dementia. We actually now call it, from a scientific point of view, we call it major neurocognitive disorder. But because dementia is a common terminology, because we are all familiar with that, we still stick on to that in some clinical scenarios. So when do we call it dementia? So the DSM says that there should be a significant decline in at least one of the cognitive domains, which can be executive function, complex attention, language, learning, memory, perceptual, motor, or social cognition. And the decline represents a change for persons' prior levels to their current levels. So, and it should be persistent and it should be progressive over a period of time, and it should not be associated with delirium. In addition to this, there must be a functional assessment as well. There should be a decline in the patient's functional assessment and how they perform their everyday tasks. So the everyday function of a patient is often evaluated in terms of the ability to perform instrumental activities. So when we say instrumental activities, that includes managing finances, medications, things that we do on a day-to-day basis. And if it's more severe, we then just look at the basic activities. So that can be like dressing oneself, self-care, being able to feed oneself, being able to make a cup of tea, those kind of things. So it depends on the severity. So it is often a progressive disorder. It is important because it is a significant public health burden. Ma'am has already explained all of this. It increases the cost of care both to the individual and to the society. And just to touch on, this is an old data which says that in 2010, based on a US study, it showed us that treating dementia was projected to be about $600 billion per year worldwide. So that's how costly it is it's a global burden, both to the individual and to the society. So when we think of dementia, is it reversible or irreversible? Well, there are some dementias which are reversible. Again, this is mostly from an academic point of view. So we can think of them as the intracranial causes, or causes within the brain, such as normal pressure hydrocephalus, which presents with gait disturbances, urinary problems, cognitive decline, which if identified and if the neurosurgeons are agreeable and if that can be corrected, it can result in some of the symptoms reducing. Then there is subdural hemorrhage or hematoma, which is very common, especially after falls. So there are some tumors which can be operated and removed, and there is there are some conditions called as general paralysis of the insane related to some sexually transmitted diseases kind of conditions. Some systemic disorders which can be reversible include alcohol intake, alcoholism, anoxia, hypoglycemia, thyroid-related problems such as myxedema, vitamin deficiencies, certain drugs, chemicals, and certain liver and kidney conditions. When we talk about irreversible dementia, this is just an overview. We'll try and go into a detail of at least some of them as time permits. So ischemia, Alzheimer's, Pick's disease, Lewy body, frontotemporal, Huntington's, vascular, Parkinson's, they are considered to be the irreversible causes of dementia. Now, they can also be thought of in terms of the position or the pathology. I know it's a bit too much, but it's just useful for us to get an overview. So it can be divided into cortical and subcortical based on where the dementias are located. So when we think about the subcortical type, we have the Parkinson's type of dementia, the Huntington's type of dementia, HIV-related, Binswanger's, Wilson's disease. Wilson's, that's associated with psychomotor slowing, abnormal events, low mood, mild amnesia, and personality changes. Lewy body dementia is one where we can see both the cortical and the subcortical features. We then have the cortical type of dementias, which can again be thought of as a frontotemporal type and the posterior parietal type. When we talk of frontotemporal, we have the Pick's disease, that is, it comes with the spectrum of FTD. We have normal pressure hydrocephalus and motor neuron disease with personality changes. The posterior parietal ones include Alzheimer's disease with memory loss and focal cognition. So with this in mind, the prevalence of dementias, especially the moderate to severe dementias, they say that after the age of 65 years, there's a 5% prevalence. And as we grow older, by the time one touches 85, there's a 20 to 40% prevalence of dementia. Dementia of Alzheimer's type, or the DAT, is the most common form. It's got a prevalence of 50 to 60%, and they occupy more of the residential homes, nursing homes, and it's quite common in the Caucasians. Vascular dementia is the next common one. It's got a preponderance in the Asian population, and it's got a prevalence around 15 to 30%. The other common, related disorders can be the head trauma related, is like the dementia pugilistica, alcohol related dementias, Huntington's and Parkinson's as well are seen as well. So coming to the dementia of the Alzheimer's type, this is the most common one. It is prevalent in the European countries, North America, Scandinavia. It's seen with increasing age. It's 6 times higher when one is older than 75. Of course, we all know that the final diagnosis is on neuropathology or autopsy. So what are the factors, risk factors or protective factors when we think of Alzheimer's disease? So risk factors, age is a definitive risk factor. Down syndrome is a definitive risk factor. Apolipo, E4, especially E4 allele, is a known risk factor. Female sex, head injury, and postmenopausal factors are risk factors with Alzheimer's dementia. The protective factors are the E2 allele. There is also the estrogen, premorbid intelligence, education. Now the story of NSAIDs, I've mentioned it here, but it's still kind of debatable. There are some studies which do not actually totally agree with that, so I'm just going to skip that. Now when we talk about the genetic factors, there are specific genes, especially chromosome 1, chromosome 14, both of them are associated with early onset. Chromosome 21 associated with Downs, especially the beta amyloid precursor protein is associated with early onset dementia. And the late onset is associated with chromosome 19. So the risk factors, so they say that the predicted risk of developing Alzheimer's in the first degree of a person with Alzheimer's is 15 to 19% compared with 5% in the controls. And the degree of risk in the first degree relatives of patients with that who develops the disorder at any age up to 84 is 3 to 4 times relative to the risk and control. So there is a risk. And then moving on to the neuropathology. So again, this is just really for information. What is it that we're actually going to be seeing on neuropathology? So it's diffuse atrophy with flattened cortical sulci and enlarged cerebral ventricles. The classic microscopic findings we see here are the senile plaques and the neurofibrillary tangles, which are nothing but cytoskeletal elements, which are phosphorylated tau proteins. It's not entirely unique to disease of Alzheimer's disease, but can be seen in others as well. It depends upon the severity of this. There is also neuronal loss, particularly in the cortex and the hippocampus, granulovacular degeneration of the neurons. Amyloid plaques are distributed in the neocortex and the hippocampus. So the neurotransmitters here, which we are all aware of, is acetylcholine and norepinephrine, which are implicated, and they are supposed to be hypoactive. There is also degeneration of the neurons in the nucleus basalis of Maynard, and which is associated with reduced acetylcholine and cholinesterase transferase. There is norepinephrine as well, which is considered to be reduced here in the locus coeruleus, and there is also reduced levels of somatostatin and corticotropin. So from a neuroimaging point of view, it's very briefly, just for us to be aware of. If we look at a healthy control and an Alzheimer's brain, there is cortical atrophy, especially the parietal and temporal lobes. And there's dilatation of the third ventricles. MRI also shows reduced gray matter in the hippocampus, amygdala, and the temporal lobes. Of course, we have more specific investigations like the PET and the SPECT, but then it's not routinely used, and it's also quite expensive. So we tend to look at the CT and MRIs and ask for the others if required. We also now have the amyloid tau, and the ones which Dr. Manjari talked about earlier on in the day. Clinical features of Alzheimer's: memory deficits, short-term deficits followed by long-term, amnesia for recent events. Disorientation for time is something that is always talked about. Language difficulties, apraxia, coordination difficulties, visuospatial skills and executive function is impaired, behavioral disturbances, psychotic symptoms. They give a survival rate around 8 years, but it can vary based on different other factors. And progression of the disease is associated with behavioral and psychological symptoms such as agitation, emotional outbursts, wandering, and in the terminal phase, you might have profound disorientation, double incontinence, etc. So poor prognostic factors include male, gender, age of onset of less than 65 years, prominent behavioral problems, parietal lobe damage, and observed depression. So that can be thought of in terms of posterior cortical atrophy, logopenic variety. So there are some rare forms of Alzheimer's disease as well, which is just really for our information. Now moving on to the vascular dementia. So vascular dementia is the second most common type, again very common in the Asians and associated with various risk factors. There are various classifications. So there was one that is divided based on the site before I go to that, how we go for an evaluation is, it's very similar to the others, a quantitative assessment, looking at risk factors for stroke, looking at history, neurological examination, neuroimaging, establishment of a possible diagnosis, identification of relationship between the symptoms and the deficits. So I'm going to skip that slide here. So types can be thought of in terms of single stroke, multi-infarct, and progressive small vessel disease. So when we talk about the vascular disease, there's usually an uneven impairment of cognitive function. It's abrupt onset and there is a stepwise deterioration. You might see focal neurological signs and symptoms and can coexist with an Alzheimer's dementia. Multi-infarct dementia is usually more gradual in onset and can have severe ischemic episodes. And the subcortical variety there is usually a history of hypertension, there's deep white matter ischemia, and cerebral cortex is usually well preserved. There is the Binswanger's disease, which is also a type of vascular dementia. It's associated with a slow intellectual decline, a generalized slowing, and the characteristic feature here is MRI with small distinct infarcts and white matter changes. There are gait disorders and dysarthria. Then CADASIL is again another form of vascular dementia. It's seen in the younger generation, people as young as in their 40s. It's a it may develop a subcortical dementia and there are white matter changes. There are focal neurological signs and deficits. And risk factors include old age, hypertension, ischemic heart disease, smoking, alcohol, hyperlipidemia, atrial fibrillation, family history. And other factors such as coagulopathies and anemias, polycythemias, etc. Now this is a Hachinsky index which we used to do in our training years, how you differentiate between Alzheimer's and vascular. I think the trainees might be quite used to it. So really if there is an abrupt onset, if there's a fluctuating course, if there are focal neurological signs and symptoms, we would think more in terms of a vascular dementia. And if the score is more than 7, it's likely to be vascular than a Alzheimer's dementia. So what is the treatment here? Basically, we're looking at controlling of the risk factors, blood pressure, antiplatelet therapy and statins, physical activity, physical therapy and rehab, and looking at the medical conditions. Acetylcholinesterase inhibitors and memantine, Dr. Manjari has already touched on, so I'm not going to discuss that here. So if we need to differentiate between Alzheimer's and vascular dementia, Alzheimer's tends to be seen most commonly in females, whereas this one is seen more in males. Alzheimer's, there's gradual progression, whereas this is a stepwise progression. Now moving on to Lewy body dementia, it is again third most common. It's seen in 50 to 20% cases of hospital and community-based samples. Here, Lewy bodies are eosinophilic intracytoplasmic inclusions, which are seen in the cortex, the limbic cortex, and neocortex. The clinical features here are cognitive decline, which interferes with social and occupational function. It's important to have 2 core features for a probable diagnosis or 1 for an essential diagnosis. So fluctuating course, recurrent visual hallucinations, and spontaneous motor features of Parkinsonism. In addition to that, repeated falls, syncopal attacks, loss of consciousness, neuroleptic sensitivity are all associated with Lewy body dementia. So Parkinson's is also a spectrum of Lewy body dementia. So how we differentiate that is usually the motor symptoms start first, then followed by the cognitive symptoms. You will have visual hallucinations and extrapyramidal symptoms here. Phenotypically very similar to Lewy body. We then have the frontotemporal dementia, which is actually a spectrum. You have the Pick's disease, you have corticobasilar degeneration, progressive supranuclear palsy, seen in a younger age group. It's seen between 40 to 75 years. Insight is lost much early on. There are characteristic behavioral problems such as disinhibition, social misconduct, lack of insight, repetitive behaviors. So on neuroimaging, we tend to see bilateral asymmetrical focal atrophy of the frontotemporal region. And then we have the CJD or the Creutzfeldt-Jakob disease. You have myoclonic symptoms, visual changes, ataxia, memory changes, behavior changes. And there are others such as the MSA and the corticobasal syndrome, which we won't talk about. It's important to keep in mind differentials when we talk about dementia. Is it a delirium? Is it a depression? Is it polypharmacy? Or all the other different factors that we talked about. So from a management point of view, so we've talked about the medication, lifestyle modification, very important, optimizing your sleep, eating, an anti-inflammatory diet, exercising, making sure sensory impairments have been corrected, looking at the suitable medication based on the symptoms, psychoeducation, carers assessment is the way forward. Carers education and support is very important, looking at polypharmacy, looking at compliance, looking at safety concerns, and the way forward is an interdisciplinary support, making sure that all disciplines work together and not as individual people, and making sure there are adequate facilities at home. So I think I've tried to cover as much as possible in this short time. Thank you very much.
Thank you so much, ma'am, for your lucid presentation. Chairpersons, can we move on to the next speaker, please? Yes, we'll have the question answer session at the end of the three speakers. All right. For the next speaker, we have Dr. Avinash D'Souza, sir. He is going to be speaking on the topic of sexual issues in dementia. A brief introduction about Dr. Avinash, sir. He is an accomplished consultant psychiatrist, and he is also a consultant school psychiatrist, working with both mainstream and special schools across Mumbai. His unique qualifications include a master's in master's in counseling and psychotherapy, an MPhil in applied psychology, an MBA in human resource development, and a doctorate in clinical psychology from the University of Hertfordshire, UK. His contributions extend internationally also as a faculty member for UNESCO Chair in Bioethics, working in over 8 countries. Dr. D'Souza is also the chief editor of the Indian Journal of Mental Health and Annals of Indian Psychiatry. Dr. D'Souza's academic contributions are vast, with over 750 publications in national and international journals and authorship of 12 books in mental health. Let's welcome Dr. Avinash D'Souza. Thank you.
Good afternoon, everyone. It's a very interesting session post-lunch to talk on sexual issues in dementia because it keeps the crowd awake. The thing is, the first issue is it actually sexual issues, or is it that the patient with dementia is having a hard time? So we tend to look at it as sexual issues. We tend to look at it with stigma. We tend to look at it with disdain, anguish, anger, resentment. But they're not doing it purposely. It's their brain that is making them do it because the brain has degenerated. Changes have happened in the brain that has led to these things happen. It is very common in practice to see sexual issues in dementia. Caregivers will come to you and talk to you about it. But the first take-home message is you need to ask about it. Because in India, talking about these things is a taboo. Not many people express, speak about these things unless you ask. Many of them think in old age these things happen, so there's no treatment. We have to just accept it. Why are we discussing sexual issues in dementia here today? Because it's very common. At least 15 to 20% of patients will report some symptoms at some point of time in the course of their illness. And they are enveloped on a wide spectrum. So you may not see full-blown sexual behavior, but you see subtle forms of behavior and subtle changes in personality that lead to these behaviors. And why it is very important? Because they add to the misery of the caregiver. And it's difficult to treat. Not all, we don't have a medication for every symptom. So it's a little difficult symptom, difficult constellation to treat. There are varieties of ways in which sexual symptoms present in dementia. I run a single doctor clinic practice where fortunately, unfortunately, I see a huge number of patients with dementia, because in the part of the city of Mumbai where I practice, we have a lot of people who have this condition where the parents are in India and children are abroad. So the parents are all alone and they undergo all these issues. So I'm going to discuss a few cases that I've probably seen and then little about what I know. The first case is what I call the collector. I saw a patient the age of 80 with dementia who started collecting photographs, images, magazines which were of a sexual nature. And he would keep it under his bed, under his pillow, in his cupboard, like how a teenager would. And once when he was taken to the hospital for a checkup, they decided to clean his room. And that was when it was discovered. And the relatives fired him that at this age does it, kya aapko ye shobha deta hai, that you're doing this. They didn't realize that there's frontal lobe damage, there's disinhibition, there's sexual increase in sexual thought as a result of that, which is causing this. But he never did anything else. He only collected, he would look at them, he would enjoy himself. That's it. So you might see a very mild part of the spectrum there. The second case is someone who speaks about sexuality. Again, they only talk about it. They joke about it. They may suddenly come up with a sexual comment in the middle of a serious conversation. Somebody came to me, 75-year-old. They said that dad is having memory loss, but suddenly we are seeing that he's sending sexual jokes on the family group. And earlier he would never do all this. And the family group has got children, the family group has got ladies, and they're very shocked that, this kind of behavior is coming up. Okay, once in a while he sent it, we didn't bother, but now it's happening every day. And he's sending it to many other WhatsApp groups, and people are now, asking us that what has happened. In a wedding when we went, he cracked a joke which was a little bit of a non-vegetarian nature. So what do we do? Third case, I saw a patient who would kiss everybody who came to meet him, male or female. So he would, and the thing is, first they thought, he's an old person, it's out of love. So as long as he was kissing them on the head, they didn't bother. But then it so happened that he began to kiss people on the cheek. Then there was a particular lady who he tried to kiss on the lips. And what happened was, as a result of this, and a few of the ladies who went to meet him, of course, women have a sixth sense of touch. So they told the relatives that, I don't think uncle's mannerisms are proper. And he was holding our hand too tight and he was trying to kiss me, I prevented it. But he would, and the thing is, they said, but no, he kisses even males who come to see him, yes. The issue became a problem when he started to sort of do this to the maid servants in the house and other people. And then there were complaints, people in the building came to know. So ladies would avoid him if he was walking in the compound. So it became embarrassing. This is another form of sexual symptom that you may see. It's not sexual symptom, it's sexually inappropriate behavior. Then we see frank hypersexual behavior. The wife says that we have probably not been intimate for the last 15 years, and suddenly he wants to get intimate. In the middle of the night, he will start touching, doing all sorts of things which are inappropriate. And I don't like it, I have no interest. But he will, try and do this. And why is this change being seen? On a lighter side, I always tell relatives, with dementia, your pre-morbid personality can either be an accentuation of in dementia, your pre-morbid personality can get accentuated. So if you are short-tempered, you will get more short-tempered. If you are aggressive, you can get more aggressive. Or it can be the opposite. If you are aggressive, you get very docile. If you are very docile, you can get aggressive. So the wife remembered that point and came and told me, since he is showing this hypersexual behavior now, do you think in his young age, he must have had affairs with multiple women? Because you told me the pre-morbid personality gets accentuated. So I said it could also be that he never did anything. Because the opposite is there. Why do you want to think negatively now at 79 when he's here? And if he did also, hell with it, now we can't do anything about it. So then she realized, she says, nahi ho sakta hai, pehle achhe the, ab ye aise ho gaye. So that is the thing. We also have people who watch adult films openly. So kissing scene comes on Netflix, he's laughing loudly. We've had an 83-year-old person watching films like 50 Shades of Grey, which shouldn't be seen openly, but with the entire family and saying, no, I want to see it. So these kind of behaviors also you see. Indecent exposure. Sometimes they come out of the bathroom nude, stand nude in the balcony, stand nude in the kitchen. They don't do anything, they just stand disrobed. So you may see this kind of behavior also. A neighbor, I remember, again, I'm not making the subject sound humorous, but it's a fact. Neighbor saw this uncle who was 81 standing without clothes in the balcony and told him, uncle, you go in, you can't stand like this. So he said, it is my balcony. I will stand how I want. You don't see if you don't want to see. So the thing is, no, so this is how their brain works. I'm just trying to tell you, their concepts are very rigid. So they work that way. They don't understand the abstractness of things. Sometimes it so happens that they get hypersexual and they may even try and force themselves sexually on a person. So we had a case where someone tried to force themselves sexually on a maid who was the caretaker, and she said, I'll file a police case. We had to intervene and explain that this is dementia related. Then we had a male caretaker. So all these kind of things also happen. You can have personalities that are exacerbated. So someone who was always hypersexual becomes more hypersexual, and the relatives, the wife will tell you that this is true. We also see some patients engage in self-stimulatory behavior, masturbation and otherwise. It happens in old age. And you see sudden outbursts of sexual behavior. So 3 months he's fine. One day suddenly there's sexual behavior. Again another 3-4 months he's fine. So it's unpredictable. You may even see unpredictable sexual behavior. Very important question, is sexuality in dementia related to pre-morbid personality? No, not always. Maybe in 1% of cases, but not always. It could be that it's something that comes up post the dementia. It's very important that old age homes that manage patients with dementia are sensitive about this. I remember I was called to an old age home because 2 old people, it's a case we published in the Journal of Geriatric Mental Health. 2 old people, both their spouses were dead. One was 80, the man was 80, mild dementia, but fairly aware of what's happening. The lady was 76, also forgetfulness, but no dementia. And they fell in love with each other. And they said, we want to shift to the same room in the old age home. And the old age home told me, doctor, you need to do a psychiatric evaluation and see what's wrong with them. I spoke to both of them and they said, if I'm 80 and she's 76 and we have little memory loss and we want to be together, doctor, what is the harm? And I said, there is no harm. I told the old age home, they're adults, they're consenting, they have the capacity to consent, the dementia is not so bad. If they want to even be in one room, what may happen? I said, there's not going to be anything that will happen out of the way. We have to ask their children. I said, no, you don't have to ask their children. The children may not have to know. It's okay. So they said, no, we will not allow it. Female ward is separate, male ward is separate. If they start, everyone will start. This was the thought of the old age home. The thing is, basic sexuality in old age is not respected. They think old age is a time where you pray. You don't think about all these things, you know. And I said, no, you can allow them. It's absolutely fine. They called another psychiatrist. They didn't change the psychiatrist. So that is what happened. So these things happen also. We have to psychoeducate relatives that these things happen. It's fine. They may touch the daughter-in-law sometimes. They may touch the daughter sometimes. He's not being a pervert. He's just having dementia. A relative told me the dementia patient is giving me a hard time. I said, no, he's having a hard time. He's not giving you a hard time. So that's the problem that is there. They need to feel. A lot of dementia patients need to feel. So they touch the nurses that take care of them. They'll hold the nurse's hand. They'll not let go of the nurse's hand. It's very normal, and nurses who work in geriatric care are aware. It's only here that we have nurses who are not sensitized at times. So they think of it as being, not proper. There's no relation between diet and sexual behavior. A lot of people think, uska non-veg ban kar do. It's got nothing to do. Non-veg soch or non-veg khane mein koi relation nahi hai. House helps and their psychoeducation. You have to psychoeducate the house help also. Uncle के दिमाग में खून कम जा रहा है, कभी हो सकता है आपको गलत बात बोल दे, छू ले, all these things can happen. It's fine. Pay her 1,000 rupees more. Tell her, you have to manage. It's because to get a new house help is a big problem, because the one who leaves will tell 10 others, don't work there. So this is what happens. You have to psychoeducate them. So I even call the caretakers and I say, ki, this is the problem with him. Is it sexual? The key thing is it sexual? Is the man thinking sexual? The man is thinking stimulation. The man is thinking feeling. The man is not thinking sexual. He is not looking for sexual behavior. Whatever stimulation he gets, he is acting upon it. And as I said, pre-morbid personality has no relation. There are a lot of organic causes. Sometimes frontal lobe gets damaged, temporal lobe gets damaged. Multiple factors play a role. We have medications that we use. People have their choices. You can prescribe a low-dose antipsychotic. You can prescribe an SSRI. You can prescribe multiple medications. A lot of medications reduce sexual activity as a side effect. We use that. Psychosocially, we educate, very important. Brain-based psychoeducation, show them on the MRI, these areas have shrunk and that's why this is happening. It's not his fault. Rehabilitation homes need to be aware, staff needs to be aware. They need to be sensitized, very, very, very important. You need to ask about the same in history. We don't ask, because we think 80-year-old fellow who's fragile, how is he going to have sexual behavior? But we should ask. And then they'll tell you, sir, no, you're right, this happens sometimes. It's only when you ask this happens. You need to keep relatives vigilant. The most important aspect is, remember that the patient with dementia was a fine young man at one time. He's reduced to a figment of his past because of the brain damage that he's going through. We have to respect his needs at times. We have to respect his feelings or her feelings at times. Let's not be insensitive. So if you see this in an old age home, be happy. Don't look at it with ridicule. Thank you very much. I'll go there.
Thank you so much, sir, for delivering the talk on this topic, on such a specific issue and very sensitive issue. Now I would like to call upon Dr. Rohan Jagirdar, sir. Dr. Rohan Jagirdar, sir, is a highly respected, renowned celebrity psychiatrist based in Pune. He has had a distinguishing career spanning over 15 years in the field of mental health. He offers his expertise as a consultant psychiatrist at several leading hospitals in Pune. Dr. Jahagirdar is also a prominent figure in media and public engagement. He is frequently featured as a mental health expert on television shows, radio programs, and also has columns in health magazines and newspapers, especially in Pune Mirror. He is also the recipient of Pune Times Mirror Health Icon in May 2021, Lokmant Health Icon in June 2021, and he has had induction into Pune Mirror Hall of Fame in March 2022. So let's welcome him with a round of applause.
Thank you. Good afternoon. Mr. Ronnie George, ARDSI, Chaitanya, thank you very much for the opportunity. Thank you all for being here today. We'll be studying about dementia again. My point being that since you don't forget and your memory is sharpened, we'll be repeating many slides. And just so that you not forget, we repeat a few things because the topic is limited to the memory and few of the data unfortunately is going to overlap. I'm going to be talking of the mortality basically in dementia and the suicidality in dementia. Essentially, what we see and what we have seen all throughout the day is speaking of dementia in terms of purely a illness, and thinking of it as, by definition, what we think, a chronic irreversible disease. It'll start, it'll progress, and of course, ma'am mentioned a few reversible causes of them, but it'll start, it'll progress, and there's not much that you can do. And that's unfortunately the attitude carried by the caretaker's relatives. It's a burnout case, it's a spent case, it's just about time and how is it gonna end. The mortality in dementia is significantly important because it's not the dementia alone that kills the patient. It's a lot of other things that come along and which can be stopped, which can be corrected, which if addressed properly can result in a far better quality of life for the patient. So worldwide statistics, again, we've already gone through all throughout the day through those statistics. We'll straight away go to how things progress over time. As you can see, the earlier where there is no cognitive deficit, which is what ma'am was discussing earlier today morning, that is there anything that we can prevent? Is there anything that we can know earlier? Is there anything that will stop us from knowing things earlier? Thereby changing the way it will progress, where there is no cognitive deficit or decline. There's a lot of research going on there and let's hope we reach there soon. Then comes what we have is the very mild cognitive decline as termed as MCI in the short form. Now the problem with MCI here is most people think of it as senile aging. You can forget the name, you can forget the relative's name, oh you forgot the time, you could not get the date right, and that's perfectly okay. At your age it's considered hone wala hai, aapki umar ho gayi hai. It's bound to happen. This is the time where these signs need to be picked up. This is that MCI, this is that mild cognitive decline where you're absolutely functional, where you're doing most things, but there are few subtle signs which are rising up, stopping you from doing few things, but you are missing it because everybody else is telling you it's your age to miss it. If you ignore them, the next thing that's going to happen is the moderate decline, where the symptoms start beginning and then people start getting and looking at you in a different way. The severe decline and to a very severe decline, which again, we know the course, how it will end up in a caretaker home or in a rehab center. The point of all of this is that all of this decline is going to have a massive impact on your lifespan. As ma'am also mentioned in her slides, that average age after the diagnosis is around 8 years. Statistically, we say that it's around 4 to 8 years of your life from the day of the proper diagnosis in moderate to severe cases. So by definition again, if you're going to go up and say that fine, I have a progressive irreversible disease, if you compare it to a cancer where they say, doctor, aap kitna time bacha hai, If you're going to ask the same question to a person who has dementia or relatives of dementia, if they ask you that question, we are looking at that 4 to 7 years or 4 to 10 years. The unfortunate part here is it's going to be progressive. The unfortunate part is it's going to be really bad. In terms of memory, in terms of physical, mental and behavioral disturbances. The BPSD as behavioral and psychological symptoms of dementia are a major part of the moderate and severe dementias. So symptom wise, you all know what you will see at the mild to moderate level. Like I mentioned, all throughout the day we have been going through these symptoms again and again. But what is important is once these symptoms are starting to set in, they are going to be the primary agents to cause the secondary issues which are going to lead to mortality. So what are the factors which cause that increased mortality in dementia? Increased comorbid risk factors like heart disease, stroke, diabetes, etc. and dementia versus other degenerative changes. Something I'm going to repeat many times right now is just because of one illness that we are focusing on repeatedly doesn't mean that that patient at that age is immune to everything else. That is not going to happen. So commonly, neurologically also, we see dementia is not the only thing. You will have an overlap of Parkinson's. You will have an overlap of some other neurological disease. We will also see that if the patient has dementia, there is unfortunately, because of the decline in self-care reduction, a lot of other illnesses, if he is carrying them before the dementia is diagnosed, they are going to get worse. But unfortunately, once we have the label in front of us, we are not going to focus on anything else but repeatedly tell ourselves he's got dementia, he's got dementia. And we are going to forget everything else. See this graph, see the last part. It more looks like a cricket statistics, but if you look at the 2019 where the COVID graph goes up, the number of deaths that have happened, and they suddenly go down in 2022, and look at the red line which is of dementia. You see the progress from 2001 to 2019 to 2022. It is compared with the green line which is ischemic heart disease, something every household and every person knows. You compare it with the black line which is the cerebrovascular accidents. Everybody knows about it. Everybody accepts those deaths. The red line is the red line of the mortality rates in dementia. See how it has progressed in the last 25 years. The quality of life has increased, the lifespan has increased, so have the illnesses of that, which will come at that stage in life. I agree to that, but look at the mortality rate alone. It is one of the highest, if not the highest, like ma'am had mentioned in the morning, 7th most common reason of dying today. 7th most common. That's pretty scary. These are the statistics. Again, if you worldwide see the death and worldwide see the global estimate of people suffering with dementia, the amount of people that are suffering and the amount of rise that it is expected in the coming years. Why do people suffer this mortality? What happens to them? Commonest cause again is of death in dementia is pneumonia, falls and fractures, malnutrition and comorbidities. The pneumonia, if you Google it also, you will find out next to UTI is the most common infection, upper respiratory tract infections in old age and in patients with dementia. One of the leading reasons for that is because of improper ability of eating, improper ability of taking care of themselves, poor hygiene. A lot of times there is a chance of aspirating things because they don't know how to eat, or there are clinical neurological symptoms which there is either rushing towards food or trying to finish them very fast. However, over a period of time, there are high chances of developing a upper respiratory tract infection. That infection goes unnoticed, leading to pneumonia, leading to other causes, and all of that results in pneumonia. Falls and fractures, again, neurologically, lack of balance in coordination, movement disorders, all of them coordinate to them falling down more frequently or having falls more frequently. Inability to communicate that results in having a fracture, but there is no ability to express and tell you that you have had pain. A lot of times there is hostility from the relatives or caretakers, so a lot of these old age patients don't open up their mouth and say, I fell down yesterday. That goes unnoticed, leading to something major, and then you have the other things that are happening. The malnutrition is another important point. Either somebody takes care of them, somebody is ignorant of them, but like we all know, the immediate and recent memory is hampered in cases of especially dementia of Alzheimer's type. Now, if I have forgotten if I've eaten right now and I keep asking for food and I don't have a very positive response for it, there is a high chances that the patient will either be ignorant towards food or forget that I should ask now, even if I feel that I have not eaten. They get confused whether they have eaten or not. Over a period of time again, leading to a lot of complications like malnutrition. Comorbidities we have spoken, the heart diseases, etc. Again, the idea here of a comorbidity is to understand that if you today have a heart condition, that would be the first or the most important thing of your day. You would not think of anything else. Not even think of when I'm going to finish, but still think of your heart disease. The point here is that you will try and focus on that so many times a day that you will not miss your pill. Whereas a person with dementia may even forget he exists, forget the taking care or taking help for the heart diseases or any of the conditions that they carry. Again, we'll not repeat the cardiovascular things, but all of them could act as a trigger in mortality, trigger in processing things towards death. So we need to have integrated strategies. Again, just because you have dementia does not mean you cease to exist as a human being, and does not mean no other illness can enter in or enter you. You may be carrying them before the dementia itself. The second part of my topic is the suicidality. Suicide now has taken, like Dr. Agashi sir said today morning, that emotions have taken a back seat. There is a World Suicide Day, or we celebrate the Suicide Day, but nobody will pay attention to the fact that these people have emotions. Avinash sir in his lecture right now so nicely said that the person is a fragment of what he was before. Imagine how that would be feeling to him, how he would feel to be a fragment of who he was. He was once upon a time a CEO of a company and now can't even button his pants. That's not a very good feeling. That's not a very happy feeling. And he has to live that for the rest of his remaining life. Not a very encouraging thought. So, all of these people, especially from the mild to moderate until they reach a severe phase, even maybe in a very severe state, don't lose their ability to feel. They may lose their ability to express and tell you, but no one's saying they'll lose their ability to feel or emote. Please understand, the basics that we were taught is when you are diagnosing dementia, maybe earlier in age 60, 65, 70, the first differentiation that you have to do is it dementia, is it pseudo-dementia, or is it depression? Dementia, pseudo-dementia, or is it depression? So depression will be the commonest comorbidity in a patient having dementia to an extent that it overlaps the condition and confuses the diagnosis. And if we ignore or choose to ignore that, we are only going to increase the risk of suicidality. Please understand that the cognitive decline does not happen in a day's time. So it's not like I'm very happy, I enjoy everything, and tomorrow I am suddenly cognitively declined and I'm very depressed and suicidal. No, that will not happen. It's over a period of time, and this can be saved, this can be corrected. There is depression, there is anxiety, and if the patient is carrying any previous history, because up till 70 they could have multiple illnesses in their life and could have taken treatment from psychiatrists multiple times before. Again, just because the label of dementia comes in does not mean all the other illnesses decide to go away. 30% of patients of dementia suffer from depression. It's only a natural reaction. For example, if you imagine that at age 60 somebody diagnoses you, says that you are going to have cancer or you have cancer, it's not going to make you feel happy. It's not going to be a very great feeling. The diagnosis itself is going to put most people in depression, if they are in a sensibility or in a zone to understand it. Anxiety, again, how am I going to progress? What am I going to do? Do I have any help? Can I use the mobile phone? Can I on my TV? I can't remember what a TV is called. I can't remember what a mobile phone is called. Who am I going to call when I need help. I can barely remember my name. I can't remember who to call for help. Is that going to make you anxious? It will make anybody anxious. Of course, yes. Are we going to treat that? But like again, sir said, if we don't ask about it, no, you will not treat about it. You are not going to care about it. You are going to see, okay, there is cognitive decline or not. The emotions are what we need to focus upon. Routine mental health checkups is what we talk, but the routine mental health checkups, not just decline in cognition, not just cognitive checkups, not just the dementia checkups. Like sir said in the morning, that if we focus on the mental health, a lot of our problems will be solved. Overall good mental health, not just aging, not just healthy, good mental health. What are the strategies that we put across for prevention? It's not unheard of. Please, this is not a thing that elderly people don't attempt suicide. It is not a very rare thing. It is not a very common thing either, I hope so. But it is very, very heard of. We need to have SOPs, standard operating procedures in place. There has to be support. There has to be psycho-education of the caretakers. They have to be made to understand. The commonest question in any psychiatric case which people ask is, इनको अकेले रख सकते हैं क्या? हम travel कर सकते हैं क्या? शायद नहीं. But you will have to understand why. Because again, standard lines that we have is, please give them a tag, write their name, write the mobile phone behind, write the address behind, because they will get lost. How they will feel, we don't care right now. They'll get lost. Okay, that's what our thinking is, or standardized thinking is. We want to know that even if they don't get lost, they are in their own room, are they really there, or they are lost somewhere? Please understand that as it will progress, it is going to be hard for the caregivers and it is going to be hard for the patient also. The symptoms are going to be fluctuating. If there is delirium over dementia is also superimposition. The symptoms are going to be fluctuating. So there are times when the patient might exhibit emotional liability, patient might exhibit real catastrophic reactions, which may not be depression, but they may act out in those reactions. By what I mean is, they may act out, they may become suicidal, they may try to harm themselves. Pain management, another very important part. Now most of your patients, if they are female, very common, there is arthritis, there is joint pain, there are other fractures that have come across. Patient is having dementia, having difficulty in communication, having it very difficult to express themselves. It is very difficult for them to understand and express that pain. It's very important. Just imagine right now that you are having some sort of pain. You are not going to be in a very happy mood to talk, to communicate, to do anything. Now you are carrying that pain continuously all throughout. It's not going to work. Emotional support, not just having cognitive exercises, and improving the overall quality of life, which is where places like Chaitanya, places where the word rehabilitation comes into play. There is a schedule, there is structured routine, there are things where they are taken care of. There is a support system. For what? For overall improvement in the quality of life. Identifying the suicidal ideation. Now, classically what we need to understand is, especially in cities like Pune and Bombay, we have a very high functioning, highly educated population. Moment they start realizing something is not right with them, especially 60 plus who are still very working, patients come with their own diagnosis, which is sometimes, most of the times wrong. But my point is, it is not that they are not aware what is going to happen. There is enough literature, enough wrong information online to scare them. But they are aware. There are a lot of intelligent people who are going to be aware how their end is going to be. So it is this place where we put right information in front and tell them that it is not always that bad. It is not that it is only going to progress. That is why the medications are there. That is why we have the medicines to basically contain and control the progression of dementia. Educating them, educating their families, educating the caregivers, and collaborating that together with the other healthcare professionals. Without taking too much time, please understand again, it's a terminal illness. It is progressive, it is irreversible, and emotionally, please understand that's not a very good thing. Once you have understood that, like sir said, respect the fact that they are human beings and being given a diagnosis. They are just not case of dementia. That would change our perspective towards them, open up the idea and put in the idea that they have the emotions, and hence will look out for mood and emotional issues as well. Once you have screened those, understand there is a potential risk, very high risk of suicidality also in patients of dementia. Thank you very much for your patient listening. Thank you all. Thank you very much.
Thank you so much, sir. Now the session is open for question and answer from the audience. Can we have mics for the audience?
Hi. So my question is to Dr. Avinash. Yeah. Sir, just on the lighter side, why was your presentation more gender oriented? It was all speaking about male experiences.
Well, maybe I would say coincidentally, in my practice, I've had male patients brought to me with these issues. So that is why I have not had so far, I would think, not even one female patient whose relatives bring them, with this issue. So most of the complaints have been in male patients. There was no issue of me being gender unequal or anything that way. So from my experience. Yeah. Maybe the stigma of bringing a lady with those complaints, maybe could be, yeah.
Good afternoon, sir. My question is to you again. You gave an example of a gentleman you talked about. He stood in the balcony naked. So we know that dementia is about lack of insight, right? So that kind of reflects that the person didn't have an insight. But when you hear them responding saying that this is my balcony and I have the right to do it, so that's another way, like this somebody who has insight only can give a very savvy response like that. So these kind of behaviors, when you see in dementia patients, they puzzle you as to whether they have a selective insight on how to kind of justify or what is it due to?
See, more than referring to it as a selective insight, I look at it as a regressive insistence to, do what they want. So, they don't have the insight, but they're like a child. Mujhe ye karna hai, I'll do it. So, it becomes more, and they just answer, like today if you ask him, he may say this. Tomorrow someone asks him, he may say something else. So the answers may vary on a day-to-day basis. On a good day, he may even listen and go in. So there is marked fluctuation in all that.
Good afternoon, everyone. My question is to ma'am. Ma'am, prevalence of dementia is increasing, and also the age of dementia, people having dementia is decreasing. So what are the causes for that decrease in age? Again, my second question is, what is the role of cognitive enhancers or nootropics we call in the management of dementia?
So first question, so basically I think what you meant is young onset dementia, isn't it? So Alzheimer's is known to be associated with longevity. So I think people are more aware of Alzheimer's from much earlier on. So the rarer causes of dementia, such as frontotemporal dementia and the other dementias, initially used to be diagnosed as anxiety disorders. So when I was a trainee, I hadn't actually seen, or I didn't know that was an FTD. So I think we are more aware of such things now from clinical experience, research and things. So FTDs are very common, and I think it depends on your experience, and FTD is not just behavior. The semantic type of, there is speech deficits, there is a language deficit, so it's not simply behavior. So things are becoming more and more prominent now from a very young onset. And so the early onset Alzheimer's disease, if there is a family history or if there are genetic factors, there is a risk of early onset Alzheimer's as young as somebody in their 40s. So I think the young onset clinics, the young clinics, the cognitive disorder clinics, we tend to see people in their 40s as well. Yeah, I think healthy aging is something that Sir has already spoken about. All of those factors need to go in. In addition to that, lifestyle modification. So what we usually see is cognitive stimulation, social stimulation, lifestyle modification. So lifestyle modification includes everything, physical activity. So research says that physical activity, physical health, mental health, diet, all of the three need to work together. One cannot be left out from the other. So you need to have adequate exercise, at least 30 minutes. They say 8,000 steps. I don't know how you can count 8,000 steps, but that is as specific as things can be. So that's very important. Then diet, we look at the Mediterranean diet. There is also other forms of diet which looks as keto diet. So fish, omega-3, fruits, vegetables, plenty of fruits, all of that constitutes what is known as the Mediterranean diet. And of course, now there is evidence for yoga and related therapies. In fact, 2 weeks back, we were in NIMHANS when we had yoga and related therapies as well, which looks into cognitive stimulation and cognitive rehabilitation. So there are a lot of things going on there. So all of this needs to work together when we look at the management of dementia.
हेलो मैम, एक्चुअली अभी तक जो डिस्कस हुआ कि जो पेशेंट रिलेटिव्स के साथ रहते हैं, लेकिन एक्चुअली मैं रीजनल मेंटल हॉस्पिटल नागपुर में मैं हूँ और हमारे यहाँ जो आईपीडी पेशेंट है 6-7 पेशेंट है जो डिमेंशिया के हैं और उसमें से 2 पेशेंट ऐसे कि वो ईगर है, जब मुझे घर जाना है, जब भी उनको याद आती है घर की बीच बीच में तो बोलते कि मुझे घर भेज दो, लेकिन वो अपना एक नाम एक सरनेम कई दूर के रिश्तेदार का एक नाम बताते हैं. तो ऐसा कोई तरीका है कि जो हम उनकी हिस्ट्री ले सके या कोई ट्रीटमेंट है या कोई इमेज मतलब मिरेकल कुछ हो सकता है कि हम उनका एड्रेस टेस्ट करके उनको घर भेज सके. ये सबके लिए क्वेश्चन है मैम, प्लीज़.
So I guess whoever can answer, but reminiscence therapy is a form of therapy that we can use here. So basically when somebody comes into an old age home, nursing home, IP facility, the first thing that we ask is get a very detailed history from the family, from the caregivers, so that we understand the person right from the time they were a young person. So their likes, their dislikes, what they were good at, what are things that they don't like, family. So we kind of take a collection of this form of album, form of book. So eventually we know that when there is a cognitive decline, when they tend to forget, we go through this and there may be some emotional connect with some things that he might recollect. So that might help. And back home, back when I was working in the UK, I haven't done that kind of treatment here. So we had people who had dementia staying in the wards who wanted to go home. So we used to give them selected hours, couple of hours where they could go home with a carer or caregiver if the family were agreeable. So those are things that we need to work around. So it might be that they can go back to certain places and they can stay there and they're able to manage for some time provided they're supervised. And then they can be escorted back as well provided it's safe. And the rest, that's a risk-benefit thing that we have to look into and then do.
मैं हिंदी में बोलूँगी क्योंकि आपने पूछा था कि ऐसे पेशेंट हैं जो घर जाना चाहते हैं. तो हम एक ओल्ड एज होम में गए थे जहाँ पे एक पेशेंट थी और वो हमें कहती हैं कि मुझे अपने घर में भेज दो. तो मैंने उनके जो केयर टेकर्स थे वहाँ पे नन्स थी, मैंने पूछा ये यहाँ पे आई कैसे. तो उन्होंने बताया कि इनको किसी ने कोई छोड़ के चला गया, यहाँ पे नहीं, पटौदी में कोई दिल्ली से दूर, कहते उसको उनको बस स्टॉप पे छोड़ के चला गया. तो अगर आप उनको घर भेजना चाहती हैं, आपको पता होना चाहिए वो खुद आई हैं या कोई उनको ऐसे अबैंडन करके चला गया है. तो ये भी हो सकता है कि अगर आप उनको कहें, उनको तो समझ आएगी नहीं आई, आप उनको कह दीजिएगा हमने चिट्ठी लिख दी है, वो आपको लेने वाले आएंगे, ऐसे करके शायद वो थोड़ी देर में भूल जाएंगी। पर ये याद रखिएगा, शायद उनको कोई घर में रखना ही नहीं चाहता था। थैंक यू।
So I have a question for Avinash sir. During your talk, we were exchanging glances, my team of counselors and all, that this is so commonly that we see in our setup, sexually inhibited behaviors, disinhibited behaviors of admitted patient. So sir agreed about whatever they feel and agreed that we need to sensitize the staff, but what is the solution? Because if it's a inpatient facility, then what is the role, any role of pharmacotherapy in this?
Yes, I did mention, I mean, pharmacotherapy does work well. So now I always remember that sometimes if they are too hypersexual, low dose antipsychotic medication works. There are some patients where we've even sort of had to use a low dose tricyclic antidepressant as long as they don't have prostate issue or urinary issue or anything like that, just so that sexual behavior goes down. And these things work. Definitely pharmacotherapy has a role. But then there are also, like for disinhibition also, we use low dose antipsychotics. So you can put your money on risperidone or olanzapine, but again, the medical comorbidities need to be looked at. So pharmacotherapy does have a role, but how do you draw the fine line between him being alert, not being disinhibited, or he being drowsy and not being disinhibited? So that's the fine line. So you start at a low dose, increase medication very slowly. In an inpatient, you can monitor on a day-to-day basis. So that's something that you can do. And it is something that, yes, does work. There are times when, like I said, if the person is probably seeing something on television alone and is very happy, it may be of a sexual nature, or there's self-stimulation when he's alone. I mean, I tell relatives, just leave him alone. It's fine. I mean, there's no need. He's not disturbing anyone. Yes, but if it's happening in a social milieu and it's causing a problem, then we have to work on it.
I come to the old man in the balcony.
Yeah.
So we
somehow everyone is very
yes,
concerned about him. Yeah.
No. What I'm trying to tell you is,
yeah.
We visited a home, and the grandchildren told us that our grandfather walks into the house wearing no clothes, and we are very embarrassed because we have got friends over there. And we told them, okay, when would you take off your clothes? He says, well, when we are going for a bath. I said, so he's looking for a bathroom. He has taken off his clothes. Maybe he wants to go to the bathroom. He wants to have a bath. Please help him to go there. And they said, okay, and please tell your friends that this is his condition and don't be embarrassed by it. And later on, when we found out, they put a pot, kind of site on this thing, and the man used to go, he forgot where the bathroom was. So he was just roaming around like that. So it could be something like that, and nothing sexual.
No, I have a rebuttal to that. My old man, after his bath, would go to the balcony that way. So now what do I do? And it would happen every day at that time. Once he's had his bath, he would come in the towel, remove the towel in the balcony. So what do you do then?
Any more questions? I take this opportunity to compliment and thank all the speakers for their very impressive and highly informative talks. I have just one last question to Dr. Shiba. Now, you mentioned that there were a lot of differences between different states in the incidence of dementia. Was there a real survey, or was it just an approximate guess by whoever published it? Because conducting a survey on dementia is not done here.
This was a Lassie study. This was a longitudinal Lassie study that I think Matthew sir is here, which looked at different union territories and states. It's ongoing. It's ongoing. This was the first wave. Why the difference? So, did you have any specific state in mind? Generally. There is this concept called, we don't know what the exact reason may be. That's still kind of ongoing. But so I think the Himachal Pradesh, Kerala, those populations, the older adult population was higher there. So Kerala had the higher population, and Jammu and Kashmir, dementia prevalence was high. Delhi had a lower prevalence of dementia. So that could be because of, as we said, factors such as education, maybe activity, all of those factors may be playing hand, but I don't have the exact data here.
Yes, I'll invite our chairpersons to the center of the stage to give memento to our speakers. I'll invite Dr. Sudarshanan sir to felicitate Dr. Shiba. I request Dr. Swapnil Deshmukh sir to felicitate Dr. Avinash. I'll invite Dr. Sudarshanan sir to felicitate Dr. Rohan. Thank you so much for the speakers. I'd like to welcome Meera ma'am to give a token of appreciation to our esteemed chairperson and co-chair. Thank you so much to the chairpersons and the co-chair. Now for the next session, we'll begin the next session in exact 10 minutes.
Diploma in Tropical Medicine and Hygiene, MSc, is an esteemed epidemiologist and geriatrician with a specialized focus on dementia research. He currently serves as assistant professor in the Department of Preventive and Social Medicine at Goa Medical College. Sir's contribution to dementia research are internationally recognized, as is his involvement in various projects as in WHO, ARDSI, etc. We are honored to have you, sir, on the dais. Sir is going to speak on the topic, prevention of dementia.
Thank you. The very onset, I'd like to thank Ronnie for this invitation, thank Madam Renu, and the wonderful hospitality at Pune. This brings back good memories. I've been here the previous Pune conference as well, and I think this is really very nice to refresh those memories. And I really thank all of you all for being here. I know that it's been a long day, and this is kind of the post-lunch sessions. In Goa, we don't really see a crowd like this. We have many conferences in Goa. We have thousands of people who register, but when you're speaking, it's only the other speakers in your session who's listening to you. So it's very nice to see so many people, and also a young crowd. It's very nice to see a young crowd. What I have done, the topic is dementia prevention, and I think from morning there have been several speakers, starting from Dr. Manjari, who's given an excellent presentation on this topic, and Dr. Sanjay sir as well, who spoke about aging and healthy aging. this has been touched upon. What I will be doing is going to give you examples of how we have done small changes in Goa in order to bring about this practice of dementia prevention. And these are all doable things. These are things that we can do which are very cost effective and using locally available resources, and how we can bring about that change and how we can actually address the issue of prevention. I will also, because we have a young audience, I'll always like to encourage students to do research, because research really impacts, brings about the evidence, and the evidence will really bring about change in the policy. So I will be talking about some of the research that I did, which is related to various topics that I will be talking about. So we know where we are. We know the numbers are increasing. We know that in 2050, the numbers are going to triple. But what we need to do, and that's what the theme this year is, it's time to act on dementia. It's time to act. We are here to make a difference and make sure that these numbers in 2050 do not reach that number. We can change the trajectory of dementia, and the best way to do it as of now is actually focus on prevention. This is what Dr. Matthew was also speaking. We need to focus on prevention of dementia, because that is the best strategy, and we have real good news as far as prevention is concerned. We also know in some countries dementia has been stabilized, and that's because of better lifestyle changes that have taken place long ago. And so if that has happened there, then we need to be able to try to implement those lifestyle changes here and try to address this growing epidemic of dementia. Now, there is a lot that comes in WhatsApp and on Google on prevention of dementia. Not everything is evidence-based, not everything is right, and you have to be a little bit cautious about what you would be doing or what strategies you will try to implement. Two good documents are the Lancet Commission's report on prevention of dementia, and also the WHO's report on risk reduction of cognitive decline. This is really evidence-based, but I must also say here is that this report or these reports are telling you what research has been done and where evidence has been found. It does not mean that these are the only strategies for prevention of dementia. There could be much, much more. As of now, we still know around 20 to 25 strategies for prevention of dementia, but not all of them have the evidence, because we don't have robust research as far as those strategies are concerned. So there is a lot that we need to do. If you look at this figure, it tells you about what needs to be done in early age, what needs to be done in midlife, and what needs to be done in late life. It also gives you those circles that you can see there, and if you can read, just to tell you what that means, the bigger the circle, it means it has a bigger impact as far as reduction or risk reduction or prevention of dementia or postponement of dementia. For example, hearing loss, and then the high LDL, which is the new entry to the Lancet report. It's the visual loss and the high LDL as risk factors for dementia is the new guidelines that have come up in the Lancet report that was released in 2024 itself. So right now we have around 14 measures by which we can actually prevent dementia. And if you look at this, just to give you an idea of what this really means, if you have 100 people, then 45 people, the people in color, we could actually prevent dementia in them. And if you say, take one item, say hearing loss, which impacts 7%, it means that 7 of these people we could prevent by actually addressing the issue of hearing loss. So that is what we need to do. There are things that we can do in early life, in midlife, and in late life. Let's get to all of these. In early life, education. Education is one of the protective factors as far as dementia is concerned, but education in early life, before the age of 20, that is what's really making an impact. 5% of all dementias could actually be addressed by ensuring that people are educated or have an education, and also remain cognitively stimulated in midlife. It's not only having education, but you have to be cognitively stimulated in midlife. What's happening in India, we see these figures from the Ministry of Education. We see that literacy has increased. There's been a big impact with free education in India, and a lot of people are being educated, but the benefits that we will see of this, 80% of people are educated. The benefits of this we'll be seeing probably 30 or 40 years later. What the impact of education in the 1970s or 1980s is what we are seeing it today. So things will change in the future, because this is something that has been addressed. What we did in Goa is also we started a unique program called the Mind It Initiative. Mind It Initiative is to try to educate school children to adopt brain healthy lifestyle. Because the one thing that we know things, it's there in the Lancet, it's there in the WHO, but how do we put this into practice? And that's what my talk is all about. How do we get these things into practice? By educating school children. So I used to speak to 7th standard and 8th standard students before, but then because when my children were in the 4th standard, the teacher asked me, why don't you do it for them? And I did it for the primary school, and it was very well taken there as well. You know, you speak to children on how to adopt brain healthy lifestyle such that they can prevent dementia maybe in the future, but also what it does, it sensitizes children to dementia. So if they have someone with dementia in the home, they can then say, you know, Mama, Papa, this is what somebody came and told us, that this person, that my grandpa could be having dementia. Why don't you take him or her, why don't you take her to a doctor and see a doctor? So that was the kind of a benefit of the Mind It initiative. In midlife, there are a lot of interventions that we need to do. Many of the studies on prevention of dementia have not shown an effect because the interventions are taking place in late life. If the interventions take place in midlife, that is where we end up seeing, we can see the benefit as far as dementia is concerned. So hearing loss and lowering LDL cholesterol is both of each of them contribute around 7, so 14% of dementia can be addressed because of that. So hearing loss can happen to a lot of people, but not using hearing aid is a problem. So it's potentially that way preventable because we need to educate. One thing, you prevent hearing loss in the first place, like telling people how to take care of the ear, don't put things in the ear whilst cleaning your ear, etc. At the same time, if somebody does have hearing loss, they can use hearing aid. So that's what we need to tell people. Visual loss also now, in the latest Lancet report, we see visual loss also contributing, visual loss in late life, things like cataract or diabetic retinopathy. These are things that are causing problems in people and leading to cognitive impairment. In Goa, hearing aid is available free of cost. So anybody who would want a hearing aid is available, not the fancy ones, but the one that you put outside, external one. You do get hearing aids free of cost, and cataract surgeries and the management of diabetic retinopathy, etc. Everything is free of cost. So we would encourage people to do this and use various kinds of assistive technology to make sure they overcome hearing loss and visual impairment. We are starting a new program with the ICMR, which I'm leading in Goa. It's on the unmet needs for assistive technology, to try to study the same thing, to find out how many people need assistive technology, they're not using it, because not using it is causing a problem. So if we try to get people to use it and encourage people to use it, these services are available free of cost, but people don't know of the availability of these services. In fact, the service is not available free of cost only to people of Goa. If anyone from outside Goa comes, they will also be given the assistive technology devices free of cost, because it's a centrally sponsored program by the government. And this project is also being done by Dr. Tambe from Pune, from BG Medical College, and St. John's and other partners are doing this study together. So we'll get to know a lot about assistive technology. The next big problem or risk factor for dementia is the non-communicable diseases. So that is a big problem that we kind of need to address. Hypertension, diabetes. I was part of the ICMR INDIBE study done by MDRF and the ICMR, and we have done studies on diabetes. This is one of the largest epidemiological study in the country to find out what is the prevalence of diabetes and other cardiometabolic disorders. We see that Goa leads as far as the diabetes prevalence is concerned. 26.4% of the people above the age of 20 had diabetes. In addition to this, 20% have pre-diabetes. So you can see how big a problem diabetes is in our region. 20% of the people had hypertension. So this is the problem. And when the question had come, why is it that different states have different prevalence? It's because one, aging is different, life expectancy is different in different states. Risk factors are different in different states. The socioeconomic status and the affordability is different, and therefore the type of food you eat is different. And therefore the same reason why dementia prevalence is different in different countries, from country to country it will vary. The same thing, each state in India is different, and therefore the prevalence of dementia in each state is also kind of different. But we see other union territories and states also very close. 26.3% diabetes in Puducherry and Kerala is not far behind. So this is something that has to be kind of addressed. Cholesterol, now I told you, has been introduced by the Lancet Commission. Even in the WHO report in 2020, where it said dyslipidemia to some extent is a risk factor for dementia, but now there's a growing evidence that LDL cholesterol is the bad cholesterol is the one that actually causes the problem. And if we actually address the issue of cholesterol, LDL cholesterol, we can decrease the prevalence of dementia to an extent of 7%, which is a good thing to do. So avoid eating a lot of processed foods, food high in saturated fats, eat food every day that help you lower your LDL cholesterol, eat nuts, seeds, fish, in a coastal area where fish is available. That is something that would give you, would increase the HDL cholesterol, omega-3, etc. Statins, yes, statins can reduce the LDL cholesterol, so it's good, but there's no direct evidence that statins will impact dementia, so we need to look into that in the future as well. We also have a national program for the control of non-communicable diseases, so this is something that is there in a big way, and it is being highly prioritized by the government, monitored centrally. We have people who would check every month the total number of new cases of diabetes, hypertension, how many people are taking the treatment. And they will check the pharmacies. You can see some of the, the Director of Health Services, the inspection going on with the pharmacy, try to see how many medications for diabetes and hypertension is available in the stock, and if it is not, it will be addressed immediately. Another big problem that we have in risk factor for dementia is physical activity. 2% of dementia could be impacted by trying to make people more physically active. Goa is known to be sushegad. Sushegad means laid back and chilled out. Not everyone is, but then that is what that's the title we have. But that's the reason why we have diabetes on the rise, hypertension on the rise, because physical activity is a problem. We do a lot of work, we are earning a lot, but we're sitting much more, and that is the problem. Sitting is the next smoking, as they say. So Fit India campaign and various other campaigns, now you'll see a lot of people, it's visible that people are getting more active, people running marathons, people cycling, people going for walks. So this is something that has to be encouraged because this will have long-lasting impact. Alcohol problem. For those people who drink, it is 1%. But what you need to also understand is a lot of people who have high amount of alcohol don't live to an age where they can actually develop dementia. So that is also something that we need to keep in mind. Alcohol is bad. 21 units, as Dr. Manjari also said, per week, 21 units per week of alcohol, more than that is a problem. So you should, maximum that you can take is 14 units. So you have to keep it below 14 units if you want to keep dementia away. So the message is, if you do not drink, please do not drink. And if you're drinking, then try to reduce it and try to keep it moderate. As Sanjay Sir also mentioned, it's sometimes difficult to keep alcohol in moderation. So if you cannot do it, please try to avoid it. And people have given up alcohol. A lot of people have done that, and it's something that is doable. Smoking, another big risk factor. Smoking, a risk factor for so many things. 2% of dementia is impacted with smoking, and the various guidelines now and laws that try to reduce the people from or discourage people from smoking. Obesity is a risk factor. 1% of the dementias are impacted by obesity. So if you address that, it is something that we can achieve a lot. Depression, I want to talk about this because as the speakers in the past also have spoken, depressive pseudo-dementia is a problem. Depression by itself, now it could be a sign with dementia, but depression by itself could be a risk factor for dementia. And depression is something that can be addressed. And we had done a small study. This was with the University of Pittsburgh. Professor Charles Reynolds, who was a geriatric psychiatrist from the University of Pittsburgh, together with us and Sangat, had done a study called the DIL study. It really stands for Prevention of Depression in Late Life. DIL stands for Prevention of Depression in Late Life. Our intervention was not medical. It was not like pharmacological intervention. It was non-pharmacological interventions all the time. And we just tried to break the cycle. People feel bad, and because they feel bad, they do less. And because they do less, they feel bad even worse. So that's a kind of a spiral that things keeps on going and keeps getting bad. Okay, it keeps getting bad. And so we had to address these issues. We also addressed the issue of sleep by doing some behavioral changes and trying to address the issue of sleep and try to get people to sleep better and see if that could impact people with dementia. We followed up people, it was a randomized controlled trial, and we followed up people for 1 year to see whether our intervention using by non-specialist health workers are making an impact or not. Now, in order to address the issue of depression and speak about depression itself, it was becoming a little bit of a challenge with older people. So what we did a lot of storytelling, and we used flip charts with stories, like sometimes when you're walking, you do fall down. When you go down, do you want to stay down? No. The same thing happens with our mood. Sometimes our mood is low. Do you want to keep it in that low mood, or do you want to come out of it? And there are steps by which you can come out. Just like this, you can see steps here, you can come out. Would you like to learn these steps on how to get out of low mood and address these issues? So we use problem-solving therapy to address it. So they would come up with various solutions, and these are the keys, the various keys. Now, which key would you like to use? That's what we would ask them, and they would then come up, okay, this is what I would try to do. Can you do that? We'll come back in a week's time and try to see whether it works or not. So we would encourage them and try to get them to find a solution and help them solve the problems that will come in the future. Not only the problems that they had at hand, but even problems that they would have in the future. This is something that they would they will be able to kind of handle with this kind of a problem-solving therapy. And it addressed physical problem, it addressed mental problem, it addressed social problem, financial problem. So there are pensions that you can get from social welfare, but people are not getting it because they've not written the form. So how will you do that? Where can you get the form? Can you get someone to get you the form? Can you fill it up? Do you need help? We can help you. So that's how we would take, instead of just procrastinating and not doing things, we got them to do things and take their health in their own hands and address that. That is Professor Charles Reynolds with me, visiting some of the homes in the community. And again, we would do everything. Like the intervention was done by non-specialist healthcare workers, like healthcare workers, or equivalent to say ASHA workers. We don't have ASHA workers in Goa, but then it's equivalent to ASHA workers, which would kind of do the intervention, but they would do it under supervision. So they would get back to us and speak to us, and then develop a care plan and go back and do the intervention. So first step was to identify what problem they're facing and then use problem-solving therapy to address the problem. And if they have 2-3 problems, we'll take the smallest problem first. So they will try to address it. They'll feel good. Oh yes, I settled it. It was there in my head for the last 6 months. I didn't do it, and now, okay, it just got settled. Good. And so they'll feel good about it, and they'll take up the other problems. So everything. So if they had diabetes, then how do you solve your diabetes? Is it under control, not under control? Why it's not under control? What can you do about it? No, it's too expensive medication. Is there a place where you can get medicines free of cost? Yes, there is. So can you go there? No, there's no one to take me there. Can you find out how can you go there? How can you work it out? Is it necessary for you to go there? Can you get someone else to get you the medication? Yes, you can. You can send a proxy, and the health center will give you the medications also if you're already registered over there. So there are ways to solve every problem. And I told you we did a randomized control trial. So one of the groups got help, and the other group got help after after 1 year period. And we saw that it made a big impact. Just to cut that short, if you see that, that's the DIL arm and the care as usual arm. And these are the levels of depression in the people, the GHQ score. So you can see in the DIL arm, the level of depression was much low, whereas the depression level was much higher in the care as usual arm. So it was a very significant difference between the two groups. We also worked with people living in old age homes. This is a project called Sarthak. I don't know if any other ARDSI chapters are involved with this. Sarthak is a project for improving capacity for dealing with mental health problems in old age homes. And this is the HelpAge initiative. So we trained people running old age homes on how to once recognize the signs of mental illness in them, whether it's dementia or depression or anxiety or any other thing, and also how to address it at their level, or what we call mental health first aid, how they can do that, and then they can refer the person to somebody else. Now, considering that, there's next, which is late life interventions for social isolation, air pollution, visual loss, as I told you, and altogether around 45% of the dementia risk can actually be modified. For social isolation, it's a big problem, and actually, when COVID happened, social isolation was kind of the norm, and that is what exactly was impacting older people more than anyone else, because they were told to socially isolate and stay at home. 5% of dementia can actually be prevented by addressing the issue of social isolation. So before the COVID happened in 2017, we started something called the Memory Cafe. The whole idea was to get people to get together, older senior citizens to get together, and have a platform wherein they can actually interact with each other and socially mix up with each other. And we had cognitive stimulation exercises for them, various kinds of exercises, and it really grew. We called it Magic Monday and Whoopee Wednesdays because it happened on Wednesday and Monday. And then COVID happened. They were very, very depressed. I mean, this is like, they looked forward, the whole week they lived in order to go for that Monday or the Wednesday program. And then we thought, during COVID time, Zoom happened, okay? So we thought maybe for seniors, Zoom, it may not work, you know. We tried it out. We said, look, let's do, because we can't do the physical meetings, let's do the Zoom meetings. We have it on Zoom, and it worked beautifully. They just learned everything on how to get to Zoom. It's very easy once you kind of overcome that barrier, the thought barrier that you can't do it. And all family members would help them. And in fact, it worked much better. Now we have people in the memory cafe who are from Portugal and Canada and from other places who just kind of join and wait and watch and really try to. So we have a very happy platform. But it's not only happiness that we're giving them, we're also giving cognitive stimulation without their knowledge, okay? So, and cognitive stimulation, as Dr. Manjari also mentioned, was not only, it's not only memory, it's about reasoning. So we have games about reasoning, various things, the various, 10-minute sessions on various things that would attend to everything. Reasoning, like you can have, which is the odd one out, which picture is the odd one out of the 6 pictures, and tell why you think so. Attention. So you play some simple games like maybe head, shoulders, knees and toes, and those kind of games that we could play. Memory, we could have various games with cards, etc. Language, we're teaching them new language, but also we have language games. Like we give them some set of 10 words and say make a sentence out of this, whoever comes with it first, or give them a big word and you make the multiple small. But various kinds of language-related games that we play with them. Learning, we always teach them something new. So right now we're teaching them decoupage, and we are teaching them mandala art and various art form, and teach them different dance programs, perception. This is some of the work that they have done, and they do the work, they learn it for the first time, they do it, and they show each other, and they encourage each other, and they're very happy to showcase the work. Others say, I'm very good at cooking, but nobody's there to eat. Or I'm very good at this art, I was very good at crochet, but what's the point of doing it now? Nobody's going to listen to, nobody's going to see anything. So this is what they show, and they're really beautiful. They're much better than what I can ever think of. And they do things that I cannot even do now. They've made some crochet dolls and things like that. Unfortunately or fortunately, it's many women have taken over, and they have actually volunteered. The project now is run by volunteers. I'm there every Monday for them, but then the planning, everything is done by them. And twice in a month, they meet physically. So in addition to the online session that happens every Monday, they meet physically, they will sing, they'll meet at various programs. And through this program, we will teach them. I run a session for them called the Sip of the Day. It's a memory cafe, so Sip of the Day, where I'll tell them various health tips on how to handle their health, etc. Head injury is a problem, things that needs to be done, make sure that you protect your head. Air pollution is a problem. We need to make sure that we breathe clean air. I'm skipping this because I've kind of told you, but I want to show you more about this. So all of them are helping now to raise awareness. We know what can be done in order to prevent dementia. We need to get this message across. And so even at the Alzheimer's Month Awareness Program, I try to get even the newspapers to talk about various aspects, but prevention of dementia is the one that they really like to speak about, and people like to hear about it. So use it. People like to hear about prevention. Have a program that's titled Prevention of Dementia. Let people come. Then at that program, you can tell them about non-pharmacological ways of handling people with dementia, understanding the signs of dementia. But they are coming there to listen to prevention of dementia. So use various ways in trying to address this because it helps, and a lot of media attention. Media, you have to be very careful with them also. Like I put on the WhatsApp group, ARDSI WhatsApp group, anyone had an article in Marathi, because we wanted to put in various other languages in Marathi as well, in Marathi papers. So then I ultimately sent an English thing only to them, and it was dementia is not a normal part of aging. That's what I had said, and I'd written about that in English. The next day's newspaper said, Dr. Amit Dayas says that dementia is a normal part of aging, so it's so ingrained in their head. So even if it was there not that I had written, they don't see it, they just see what is there in their mind, and that's what's there. So that's a big challenge for all of us. And if you've seen the ADI report, we have actually gone down in some of the areas. Instead of improving the knowledge of people, things have got worse in some pages. So we have to work a lot in trying to address the issues, trying to address in various other languages. We also started something called the Move to Prevent Dementia. Really, it means you need to get people to start activity in order to prevent dementia and address the issue of physical activity to prevent that. Very quickly, when we're dealing with problems of people with dementia, we should not forget the caregivers. And you can prevent a lot in caregivers as well. And our study in the past has shown that we can prevent caregiver burnout, and we use this strategy called the care intervention. C is one caregiver. Understand the signs of caregiver burnout and address the issues of the caregiver first if you want to do anything for a person with dementia, caregiver comes first and address those issues. A is about reminding us on activities of daily living that can be assisted, and also behavioral problems in people with dementia. R is about rehabilitation, so reminiscence therapy that has been spoken about. So that is what reality orientation, etc. And E, very important, Dr. Manjari also was talking to me about that, is environment of the house, whether it's the physical environment or the mental environment. The way you talk to a person with dementia, that also has to be very positive. And the physical environment, declutter, keeping your signages, etc., makes a big difference. So again, we did this through lay health workers to deliver interventions in homes of people with dementia, and it was a randomized controlled trial that showed a big, so you can see some of our workers visiting the homes when the study was being done to address various issues of the people with dementia in this manner. And it showed a big impact to reduce the stress in the caregiver and improve the quality of life for people with dementia. This is the 1066 Dementia Research Group that Dr. Matthew is to coordinate. This really stands for the fact that only 10% of the interest of funds for research in dementia goes to an area which actually 66% of people with dementia live in the low and middle income countries. So we need to encourage, and that's what I want to tell all the youngsters here, good quality research, not doing research for the sake of doing research, but good quality research will help generate awareness, will encourage service development, and will help shape policy. So we need to have evidence-based policy making, and that's a picture of the, you have Meera and others are there, no? Yeah, Matthew and others are there. So that's when the dementia and the report was first kind of released. So we try to package our education programs and try to make it very simple, like secrets for cognitive health. This is just one of them. We'll say stay active, S for stay active, E is for eat well, N is for nourish social connections, I is invest in lifelong learning, O is organize your environment, R is rest well or sleep, and S is seek help whenever you need help. So thank you for your patient listening. Once again, I would like to conclude that it's time for action. The time is now. Thank you.
Thank you, Dr. Dias, for the brisk presentation. In fact, yours was more evidence-based presentation. And congratulations for the Herculean task you are performing in care of senior citizens and dementia in particular in Goa. That will really make us say it's really Sushegat Goa. So I think there is some change, as I'm told by the organizers, in the order of the speakers. Dr. Dias, you can please come and sit. We can take the question and answer afterwards. We have Advocate Asim Sarode, who will be jumping over the queue.
Since he's done the introduction, I'll go on with the description. This is our next speaker is Advocate Asim Sarode, sir. Sir is going to speak on the legal aspects of dementia. Sarode sir is a distinguished human rights thinker and social legal lawyer. He's committed to protecting constitutional rights and driving social change through legal frameworks. He's also a prominent environmentalist and a member of the State Mental Health Authority. He assists doctors with medico-legal issues. I welcome you, sir.
Respected chairperson of this session, Dr. Kumawat sir, Dr. Vaimule sir, Dr. Watve sir, Dr. Deshmukh, and one of the organizing committee head of this whole program organization is my friend Dr. Ronnie George, and all ladies and gentlemen, dignitaries sitting off the dais. Actually, law comes the last, but because I have to go somewhere, I jumped in between. I'm thankful for giving me this opportunity. I will just take 10-15 minutes of your time. In dementia also, law comes last, because legal aspect of dementia, not only dementia, but of everything in the Indian society is on the last bench. People don't think law as important tool to resolve problems, but they see law only as a tool. Sorry. Tool when we get into some problematic areas, some complexities. In reference to dementia, I think legal aspect and consideration of legal aspect in the initial years of identification of dementia is very important. On dementia, lawyers cannot work alone or in isolation. Unfortunately, the legal education, not only in India but abroad also, brings some wrong sense in the lawyer's mind that they know everything. But according to me, dementia and mental health related issues shall be resolved or addressed by lawyers in collaboration with doctors. So understanding the issues and problems and various aspects of complexities in dementia, talking with the doctors, discussing with them, and open-mindedly accepting that lawyers know the law, but they don't know the mental health. So aspect of mental health and understanding of it can give better solace to the patients or persons living with dementia. Unless and until we will not get an assessment report by any expert doctor, we cannot give solution, is the fact, and that facts needs to be accepted. An expert in the field of mental health can apply his expertise and evaluate the patient and its capacities. So then we can apply our legal mind to the solution oriented whatever points we are having in the law. Medical decision making and advance directives are two different things. Medical decision making might be is important when doctor along with the family members and patients take decision of giving some treatment. But that is not sufficient many times when it comes to decision making and planning for some advance directives. Legal aspect for consideration when someone is going through dementia are very important, because again living will is not that much popular in the Indian context and Indian culture. We were working for advancement and propagation of living will, because living will is an important document which can be important to protect the rights of the persons living with dementia as well as their family members. Living will is or it can be done by a person who is sufficiently mentally aware and in his own or her own capacity can make decisions, can understand the repercussions, the issues around the rights and duties. Again, there is another provision in the law which is about making or giving some power of attorney to some person who can be authorized by that person living with dementia to take legal decisions on behalf of that person. So naturally that person to whom you will be giving power of attorney should be honest, close to you, and he or she will be able to take decisions in your favor, in your betterment. Many times lawyers are also taking power of attorneys of such persons. Sometimes it is found that some organizations providing some mental health services also take some undue advantage of some power of attorneys. So that should not be there. And it is not only lawyers and the mental health organizations doing this, but it is part of tendency of some human beings to exploit some other persons who are incapacitated of taking decisions. Informed decision making is very important nowadays in the eyes of law. Previously it should be discussed only in the company laws or contract laws that consent shall be there. But now it is not only consent, but informed consent and educated consent is what we are talking more. Because informed consent means giving full information to that person, and that person should understand pros and cons of that issue and aspect when he or she is making some document. So giving the consent with informed knowledge and educated consent is very important. Legal capacity of a person and identification of legal capacity is also one of the important aspect. In countries like US, they are making dementia care plan, and that dementia care plan is being made with participation from doctors and lawyers who are taking care of that patient. So we are not having such advanced way of functioning or working in India, and a well-written document like a dementia care plan can definitely protect individual rights as patients, and they can be kept in more comfort in their remaining life. Then the court intervention is also very important. As I told you that advocates considers them throughout the world and more in India that they know everything once they become lawyers. So judges are more victim for this concept that they think and consider them as they know everything and they are next to God. So unfortunately, we should have some culture of working together and taking experts' opinion. If you go to the US or some other countries, they take participation from the experts, accepting that they don't know about some expertise field where they need to take expert advices. So taking expert advices and then pronouncing some judgment or then deciding what shall be the court's intervention legally, that is more important to make the judiciary more active and prompt with accurateness on the issues related to mental health. Evaluation of decision-making capacity is also one of the important aspects. Now in the law, capacity and competency are two different words, and though they are having some minute differences, the capacity is generalized terms, but competency is very important term in the eyes of law. So any adult who presumed to be competent, unless proven otherwise, is considered as competent to make something. So again, a legal problematic area is if some person has made some document and unless and until it is not challenged and it is not proved that that person has made the document when he was going through some process where he was not in a condition to understand something, that needs to be proved. Unless and until it is not proved, that document is good in the eyes of law. So here also we can see some legal complications, and then lawyers put their brains together to quarrel for whatever side they take, from whatever side they give, they have been given fees. So here, where is the aspect of persons living with dementia? So if we consider them as victims of something, victims of aging, victims of old age, then that victimization shall be stopped. And once we consider them as victim or persons in need of care and support, then all institutions shall bring their hands together to support them. So making the situations complication is not the job in such cases, and that's why we require very good lawyers sensitively working on the issues related to mental health and especially with the old age persons. In India, we don't have any specific law which can address the issues of persons living with old age. When I was working with Dr. Sharat Chandra Gokhale, that time I got first time introduced to such issues, and he was very prompt in drafting many things and suggesting to the government that we shall have some good piece of legislation to address issues of old age persons. Now, testamentary capacity is also important, and testamentary capacity cannot be checked by advocate. He has to take help of the doctor or mental health expert. And here also we require honesty. If doctors and lawyers, they decide that they should work with dishonesty, then there is a space. There is a space to do some harm to and reputation, harm to the reputation and property of that person living with dementia. So healthcare decision making is very participatory process, and that is not defined in law. So law are sometimes, just words written in some black letters. So making them live requires the application of mind, judicious mind and legal mind. So honesty is the important part when it comes to acting as lawyer for such people living with dementia. Elder abuse law is also not present in India. In the US, they are having very specific law addressing mental capacity act also there. So mental capacity act is not in India. We are having some vague laws. So though the mental health care protection law has brought in some different aspect of it, but still we are lagging behind in foreign, in comparison to the foreign countries. We are not having good laws at place. Making a will is very important. Like when you are, the person with dementia is in a fit condition to take decisions, at that time making a will of that person is very important. And will can be changed any time. So doctor can give certificate and certify that this person is again making a will and he want to make change in the will. So changes can be made on many occasions if the patient is in good health. The United Nations also came up with convention related to rights of the mentally ill person. But India is not showing any reflection in any of the laws addressing the international perspective in its legislations. There are various aspects of it, but I have been promised by Dr. Kumawat that he will cover everything which I will leave and I will not mention. So I take your leave and thank you very much for hearing me.
Thank you, Asim sir, for this informative lecture. Now, we move on to the last session for today. This is a video presentation. Our next eminent speaker is Mrs. Nilanjana Maulik. Ma'am is currently Secretary General of ARDSI, Calcutta. She is the Fellow at Commonwealth Association of Aging and Master Trainer of Dementia Care Skills from Alzheimer's Disease International, London. She holds a triple master's degree in sociology and social anthropology from North Bengal University, management of human services from Brandeis University, USA, and dementia studies from University of Stirling, UK. Thank you, sir.
My apologies for choosing this online format to deliver my talk. I needed to be back in Kolkata on 27th evening to travel another 580 kilometers for an awareness campaign, this being World Alzheimer's Month. Hence, to save time, energy, and of course resources, my decision to meet you all here. Thank you, ARDSI Pune chapter, for inviting me. It is good to be back on your platform after 2011. When I was asked to share the subject of my talk this time, I wasn't sure what that could be. My last talk at Pune was about the balancing act of family caregivers in their journey of caregiving. Today, after 13 years and much deliberations, I decided to stay focused on the same family caregivers, but this time shifting the story to the mistakes committed by me as a care professional while supporting the caregivers of persons living with dementia. Those of you present here today who support the caregivers in their journey, first of all, thank you for your dedication and time. Your contributions make a significant difference without a doubt, and that is because caregivers of people living with dementia, we all know, face immense emotional and physical challenges. But how we do that, meaning how we deliver that as professionals, I realized is important. And so today I would like to share my experiences learned from my mistakes over the past 30 years of journey in the field of dementia care. The lessons learned are definitely not out of any textbooks or checklists. It is purely from the daily experiences and feedback that I have gathered from my professional life while spending hundreds and thousands of hours with caregivers who care for their loved ones with dementia, which we all know is a progressive degenerative disease of the brain and unfortunately has no complete cure at this point of time. Let me begin by asking you all one question that is something that I experienced way back in the early 90s when I began my journey with dementia caregivers. And my question is, are you ever afraid or uncomfortable in what to say, what to do when you meet your caregivers? I have been, and many of us are probably so. The reason being, we really don't know how the caregiver's life is going at their end. We think we do, but actually, if you are really truthful, you will agree with me that you don't most of the times. So I asked myself, how do I understand the challenges, the pain that the caregivers are going through? My answer came in shape of self-questioning my own beliefs, values, and attitude. I realized that the more compassion and understanding I have for my own needs and limitations, the more energy I have to appreciate the needs and limitations of those who depend on me. In doing so, I identified my first mistake, and it was the way I was trained to see people's broken life and fix it. Somewhat like a watchman who looks for a broken part of a watch and fixes it. Sadly, it does not work that way. One has to be more of a nurturer than a watchman. Our job is not to fix the caregiver's life, but to nurture their well-being. Here, I started to think of my well-being and imagine if I am a plant, what shape am I in? Am I healthy? Am I sad? Am I alive and kicking? I close my eyes and I let it appear, the state of the plant that I am in, and then ask, what does it need? What can I do to meet the needs? This exercise helps me see clearly what and how to contribute well and make a difference in the lives of the caregivers. And I will earnestly request you all to walk through this exercise when you get some time. And I promise you it will help you a lot. Thank you very much. Reflecting on my daily encounters with families, I realized I was never smiling when I was with a caregiver, assuming that would demean their state as they had less or no reason to smile at all. This second mistake was rectified when I received a postcard from one of my friends who was traveling, and it said, "If you don't have a smile, I will give you mine." Things have been much better after I have started to share a smile while being with them, and I hear many of them say how hopeful they feel looking at me smiling. Believe me, this works wonder. Alternatively, I also avoided assuming they are fine based on their appearances. Just because a caregiver seems to be managing well doesn't mean they don't need support. My third mistake was the way I was communicating with the caregivers. How and what I said either destroyed or made their day. So choosing words wisely is the key. And maintaining positivity is a must in our communications, whether it's through the words we use or through our body language. I always remember that a caregiver cannot afford a single negative thought ever. However, I am also careful not to force positivity and certainly avoid pushing them to look on the bright side when they are needing to express their frustration or sadness. My fourth mistake was focusing on things not practical. I realized that if I really want to support, the best thing is to offer real help. It could be like running errands for them so that they can rest for a while, or it could be taking a walk with them instead of saying they need to take care of their health. Or it could be window shopping and watching a movie together instead of saying they need to do something good for themselves. I avoided offering empty promises. Making promises I can't keep can erode trust. I only offer to help when I am sure I can follow through it. It's better to under-promise and over-deliver than to leave a caregiver disappointed. My fifth mistake was expecting the caregivers to be empathetic towards their loved ones with dementia. Well, that's what I was taught over the years at trainings, seminars, books, journals. So passing my knowledge to them was a must, and I did, and I failed miserably. Learning to be empathetic is a tough skill to put into practice. Generally, being so with people living with dementia is a whole different ballgame. So I asked myself, can I really help the caregivers learn to be empathetic? And if so, how? One intervention that worked well was inviting them to observe more experienced professional caregivers practice empathetic responses in real life situations, at our daycare or maybe at a home setting. This was done instead of theoretical explanations and lectures or handing over a manual and expecting them to learn and implement being empathetic. The sixth mistake was always telling the caregivers only about the changes in their loved one's brain and not letting them know that their own physiology is also a part of the dynamics. And now, when caregivers ask me what they can do to help their loved ones, my response often surprises them because it has nothing to do with their loved one's mind and everything to do with their own. I urge them to invest in their own brain. My final lesson learned was from the mistake of multitasking while being with caregivers. I was never fully present with them and hence never connected. Over time, I made sure I finished all my pending business when I was seeing them and dedicated my time completely. Ladies and gentlemen, time teaches us ways to adjust and adapt. As I close, 2 more lessons that I must not forget to share. Number 1, remembering to dress and look bright when visiting a caregiver. And secondly, not to expect caregivers to achieve their well-being within a deadline. Actually, there is no timeline or race to the finish line of this journey. The idea is for you to support the caregiver, build a sense of satisfaction one brick at a time based on what works for them at that point of time. As a caregiver for my father, who died of multiple myeloma 10 years back, I guess the personal experience of mine made me discover one of the best secrets of well-being. I was searching for happiness while he was battling for the disease and after he was gone. But someone close to me told that I was searching for the wrong thing, since a continual state of happiness is not attainable. In fact, it creates a sense of inadequacy because happiness is just an emotion. It can never be sustained. It's just a feeling when you get when you see a sunrise, or maybe when you receive a positive text from someone, or when you are holding your new grandchild. Rather, he said, feeling satisfied throughout the day or feeling satisfaction at the end of the day is a much more achievable and healthier goal. It's basically a feeling of contentment and peace. It's how you feel when you accomplish something you set out to do, like giving a good bath to your loved one, or reading out a story, or holding their hands while they are sleeping. And this feeling can be long-lasting. Hundreds and thousands of family members who I met over the past 3 decades always tell me that they are failing to be happy anymore. And I tell them now and insist that they should work on feeling satisfied, not necessarily happy. That's all for me. Thank you for listening, and I wish you all a great time at the conference. Missing the opportunity to meet you all in person next time maybe, and until then, bye for now. Thank you so much.
We would like to take some questions from the audience, please. Any questions?
Dr. Amit Dias. Lovely presentation as always. Wanted to ask you, given that we know well that hypertension and diabetes and LDL are risk factors for dementia, in terms of prevention, would it also be good for us to have targeted programs for people who are diagnosed to have those things at any stage of life? And if we were to design such targeted programs, how could they be structured so that people start tracking their cognitive health in the same way that they track their heart health, or they track their hypertension or their diabetes or anything else?
Yeah, perfect. I think definitely it's something that needs to be done, and it is being done under the National Program for Control of Non-Communicable Diseases. They are trying to address diabetes and trying to ensure that the control is good, trying to ensure the HbA1c levels are under control. They're not doing it for the purpose of dementia prevention, but they're doing it for the control of diabetes, and that's okay with us, because if they're going to control the diabetes and hypertension and heart disease, they're going to ultimately control dementia.
So a linked question, Amit, is that okay?
Yes.
If I ask a question? Yeah, so a linked question. So I wanted to ask whether in your programs, wonderful presentation as always, and lovely to hear all the work that you do. I wish you could extend it to many other chapters of the ARDSI all over India, and I was just asking, is it open to other people to attend? Because there's a program like Vayamanasa Sanjeevani which is going on at NIMANS every Monday. Elders can log in and attend this program 3 to 4 in the evening. So similarly, I wonder whether you can open it up, the Zoom program, to everybody. It'll become a little chaotic, but hopefully if you can open it up. But the question was, is your program linked to the many national programs there for old age problems? There is the NPHC, there is a national program for communicable diseases prevention, and many other programs. So National Mental Health Program, is it linked? In your state it's probably easy to do that.
No, it's easy to do that, but this program is standalone. We're doing it ourselves, and it's done by volunteers. It started off small, but now it's kind of grown, and it's self-sustaining in that sense, but it's not linked to them. But I agree with what you're saying. It's definitely a very doable, ideal model that can be replicated and should be replicated in other places as well. we are trying to get other people within the pockets. See, the thing about the reason why it runs is because we have managed to build that fellowship among the participants. So they come on Zoom, all right, but they also meet. And so they want to see the other person and want to know, how are you? You're not feeling well now, how are you today? Type of that kind of feeling is there, that connect is there. So that happens when you have these smaller pockets, when you get people from all over. It could become a little chaotic, as you're saying. Language could be a problem, and their interests also could be different. So we need to get like-minded people together. I do see a drawback of this program. Only the people who are interested in doing mandala art and the ladies who are interested in doing crochet, they are kind of getting together and doing it. So the men are somewhere left out. And now how do we get them involved? I have to think out of the box and see what would they be interested in, football or something like that, to get them inside. So, but it's a good start and a good model. It needs to grow, and we are open to others, but kind of, there's the capacity of WhatsApp groups, and so that much. As of now, we have around 200 people who are part of that.
Is a stroke linked to Alzheimer's dementia?
Yes. So we have things like vascular dementia. So you have less blood supply to the part of the brain that deals with memory. Stroke is, yes, definitely. Anything to do with the heart is linked to dementia. And so if you're doing these strategies for prevention, and somebody is going to ask you, okay, well, it's not a priority or no, it's not that. Whatever you're going to do, control diabetes and hypertension and heart disease and LDL cholesterol, it's going to prevent dementia, it's going to prevent heart disease, it's going to prevent your liver it's going to prevent kidney problems, it's going to prevent everything, it's going to provide overall health. The message is actually the same that you would get in all the NCD programs. So this is something definitely worth investing in and trying to push for prevention.
Yeah. Hi. So I'm not able to understand the correlation between hearing loss and dementia, because when you talk about NCDs, you understand there is the vascular component might play a role. But when we say that 7% is because of the hearing loss, and then we say that, okay, using a hearing aid can reduce the progression, I'm not able to understand that as to what pathological process connects the two.
Yeah, excellent question. Yeah. So it's about use it or lose it. So our brain is stimulated by various senses, and that's the reason why even visual loss is now also seen as a risk factor for dementia, because what we see, our brain starts functioning, reacting to things that we see. Our brain starts functioning and reacting to what we hear. And if we don't hear, then that part of the brain will say, okay, let's prune, let's chill out, and the cells will end up going to sleep and not functioning. The other thing about hearing loss is very, very interesting, is because the hearing centers is very close to the part, the temporal lobe, which is very close to the part of the memory centers, and therefore anything affecting hearing also affects the memory. So it's very important to keep your hearing intact. So having hearing loss is not a problem, but stopping the stimulus altogether is a problem. So use your hearing aid so you can hear and stimulate your brain, and things will function.
Okay. So just one more question that came to my mind when we were talking about the middle life, and you mentioned about not having enough cognitive stimulation in middle life can also be one of the risk factors. So I was just thinking aloud, think of the rural India, right? So in early life, one of the risk factors is lack of education. So let's say females, most of the females in rural India do not get enough education. And then you look at the course of their life wherein they are mostly homemakers, right? So isn't it so subjective that what constitutes enough cognitive stimulation? A typical female in rural India who hasn't had enough education, and she's spending most of her life running her house, which itself involves a good amount of cognitive stimulation. But I just want to understand, is it so subjective that can we consider them not having enough cognitive stimulation as compared to their counterparts and say that, hey, probably they are at higher risk? I was just thinking.
No, definitely not. Because all that is cognitive stimulation. They're learning something new, they're learning to survive, making things at home, making a new dish, painting something in the house. And they are very creative. So that is also cognitive stimulation. It's a different kind of cognitive stimulation, but it is cognitive stimulation. In fact, more than the counterparts in a city who will probably buy things and outsource things that they do not do it themselves. That it kind of will affect the cognitive stimulation. But here she's doing it herself. That is cognitive stimulation. Yeah.
Oh, thank you.
Any further questions?
So what really kind of got my attention was you talking about dementia to school children. So this was something really new. I want to understand that, isn't it different that if somebody in the family has dementia and then we psychoeducate the child of the family as to what is happening to granddad or grandmom versus talking to children in general about dementia, wouldn't that kind of create a little fear? This is number one, because I remember the time when there was that Tare Zameen Pe suddenly had come, and then every other mother wanted to be sure that, oh my God, does my child have dyslexia? And we are also noticing now, even in middle age, when we just tend to be a little forgetful, maybe vitamin deficiency, maybe pseudo dementia, and we are suddenly like, oh my God, is it dementia? So now getting that to the level of children in general, what has been your experience like?
Good, very nice question. And it was there in my mind also. That's why I would do the training only in little bigger children, 7th standard or 8th standard. But when we did it in younger people also, younger children also, it worked very well. They don't connect it the way you're connecting it. They're not looking at it, we will end up having the problem. They look at it, there is someone else who's having it, and we can help. And what the person has told us, what can we do to prevent the brain problem from taking place? And the way I do it is I'll show them a film, get them to interact, tell them all the brain healthy activities that they could be doing, and it works brilliantly. So it works very well. Yeah. You know what had happened, why I did this is because when we were going house to house and dealing with people with dementia, there was one instance where there was the grandfather had dementia and the 3 children in the house. And they're playing like they will touch grandfather and then go hide. And then he would look around getting very annoyed, like, what's happening, where's the noise coming from? So for them it was a joke. But for grandpa, it was like, what is happening? People are there around this place and I can't see them type of things. It's not very sensitive to this problem. So I thought that we need to sensitize children, and keeping in mind the fact that dementia is so prevalent, and in India, families are living with people with dementia. So I thought it's the best way to actually get the message to every family through schools.
Yeah, I think it's great to teach young children and adolescents and young adults about this. And I think it works, and there's actually evidence to show that it is good. You can use a buddy system or a buddy program. It's definitely something that you can use. And to add on to the question that Neha asked, during COVID we saw that people who had hearing loss, vision loss, and sensory deprivation and loneliness, many of the people who I saw, we started thinking that they had dementia, but when we rectified all those things, they probably had just MCI, or they were normal. Many of them became actually normal people who were in their 80s and 90s. But just looking at your Manjari's and yours and Sanjay's risk factors of those 14, 15 risk factors, I was looking at, okay, what connects all of them? At least 7 of those risk factors is connected to this device. So I think this should come with a health warning, for isolation, no social stimulation, loneliness, obesity, inactivity, smoking, eating junk food, all this, it should come with a health warning.
Very good. I think that's a take-home message. It's destroying families as well. Yeah, it's true.
I just wanted to add one thing to the question on rural women. Referring to what Dr. Agashi was talking about this morning, that emotional interactions have a very great role to play in the laying down of memories. And we know this even from the experiment that was done in the US in universities, when they asked people, what were you doing the moment Kennedy died, John F. Kennedy died? And most people could remember what exactly they were doing. So emotions have a great role to play in memories, and I think women, especially who are nurturing and caring for their families, have a huge advantage there in many ways, because you were saying, what will I do with the guys? Apart from Fenny and football, what can you do with the guys? So I just want to say we should be very reassured that people caring for their families have great emotional experiences.
And that's exactly what Dr. Mohan Agashe was saying in the morning as well. So this fits in very well.
If there are no further questions, I would like to request Dr. Bailume sir to please felicitate Dr. Amit Dias sir.
Just a minute. Hello. One question is there. Is there any support group for persons living with dementia in India?
There are multiples.
So it depends on where this person is, and we can help you get into that support group. If not a support group, at least the organization of ARDSI has various chapters all around India. So yeah. So from where is the person who's asked the question has not really identified themselves, so they're. But you have not said from. Are you from Pune? Then ARDSI Pune will help you out. ARDSI Pune will help you out. Please contact Ronnie and team.
I thank all the speakers for giving nice presentations, and we had also good interactions also. I thank organizers for giving me opportunity to co-chair this session. Thanks.
Thank you, sir. So I would request you, sir, Dr. Bailume, sir, to felicitate Dr. Amit Dayas, sir. I would like to request Dr. Vijay Kalbande, sir. Sir, please, could you please come to felicitate the chairperson and co-chair today? Thank you very much, sir.
Good evening, everyone. And Sir has come for our movie date. And we have been awaiting this evening. It's a special evening because we have something very different in store for all of you all. Amidst us are two people from the fraternity of art, movie, and theatres. Dr. Mohan Agashe, who has already mesmerized us in the morning, and we all have come here and booked our seats for him. We also have amidst us Mr. Partha Akherkar. He has around 28 years of experience in theatre, English, Hindi, and Marathi. The most special thing about him is that he is the writer and director of the movie Antarnaad, The Voice Within. This movie is the winner of prestigious Dada Saheb Phalke Film Puraskar, and it was screened at the 7th Cannes Festival 2024 amongst 18 other awards globally. I think it really deserves a big hand. Welcome, Dr. Partha. Thank you for being with us. So can we please have you ahead? Can we please have you? I asked Sir if he would like to talk about the movie before we play it. He said the movie will speak for itself. However, just to give you a brief, Antarnaad stands for The Voice Within. It is a heart-wrenching musical set amidst two different worlds. A normal woman stuck in an abnormal world, and an abnormal woman stuck in a normal world. This human drama is a social film encompassing a mental health condition, dementia, its impact on humankind, and our narrow-minded, myopic approach towards the same, driven by ignorance, apathy, shame, guilt, and thereby its repercussions. Playing now before you is Antarnaad.
ये फिल्म समर्पित है उन तमाम लोगों को जो 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 अरे कुछ याद क्यों नहीं आ रहा?
Dear Mrs. Savitri Sunil Khare, we would like to request you to buy new school uniforms for Miss Mini Khare and Miss Sonu Khare, as the ones they are using have been completely soiled and are not wearable as per school standards. Thank you.
विकास,
हाँ बोल कर।
थोड़े पैसे चाहिए थे।
अरे सावित्री क्या मजाक चल रहा है क्या? अरे पैसे पेड़ पे थोड़ी ना उगते।
जानती हूँ पेड़ पे उगते हैं। इसीलिए तो तुमसे मांग रही हूँ। कैसे ये धागे टूटे न धागे।
माँ जी क्या हुआ?
बाथरूम 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 बाथरूम।
इस जीवन के तराने है सुरीले या निराले, यूं
से बात भी नहीं रही। क्यों? Why?
क्या करूं? बद से बदतर बन रहे हैं संजोग।
अरे वही तो मैं कह रहा हूं, दिन ब दिन तुम्हारा परफॉर्मेंस घटते ही जा रहा है। कल तक 50 बैग बेचती थी, आज सिर्फ 36।
तुमसे क्या छिपा है? सब कुछ तो जानते हो। अब छुपाओ ये हालत।
अरे सोचो, अपने आप को संभालो और ये सब में से निकलो जल्दी बाहर। और कोई चारा भी तो नहीं है। बस मैंने कहा वही करो। हाँ? सुनोगी मेरी बात? मैंने कहा वही करो। क्या हुआ? पता है क्या नवीन? कमाल है। सावित्री,
दरवाजा खोलो।
मम्मी दादी फंस गए।
मुझे बंद क्यों किया है? दरवाजा खोलो ना, खोलो जल्दी खोलो। मुझे बंद क्यों किया है? सावित्री।
हाँ माँ जी, खोल रहे बाथरूम।
दरवाजा खोलो।
संभाल के।
मम्मी दादी निकल गए।
लो, हो गए तैयार, वो भी एकदम सही टाइम पर।
दर्शन भी अच्छे से हो जाए बस।
हो जाएंगे, हो जाएंगे, इसलिए तो अभी जा रहे हैं। चले?
कितने दिनों के बाद बाहर निकले। भगवान करे जल्दी ठीक हो जाए।
हो जाएगा, इसलिए तो दर्शन करने जा रहे हैं।
मेरी वजह से आपको कितना झेलना पड़ता है। क्या क्या करना पड़ता है।
आपसे कितनी बार कहा, सब मत सोचिए। अब सब अच्छा ही होगा। आप यहाँ बैठिए, मेरा इंतजार कीजिए। मैं बस ये पैक करवा के आई, कहीं जाना मत। हाँ,
हमने मना किया है ना, मम्मी आएगी फिर लेंगे। कब आएगी मम्मी?
आएगी बेटा, जरूर आएगी। मम्मी ने बोला है ना तो जरूर आएगी। भीड़ होती है ना, इसीलिए देरी हो जाती है। मैं भी बैठी हूँ ना तुम्हारे जैसे।
वो देख, मम्मी आ गई। मम्मी 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 मुझे आइसक्रीम चाहिए।
ओके बेटा, चले।
बाय दादी।
देखा, मैंने कहा था ना मम्मी जरूर आएगी। आपको कुछ चाहिए आंटी? कहीं छोड़ दूं? अरे नहीं बेटा, बहू आती ही होगी। भीड़ भी बहुत है ना आज।
देखिए ना, मुझे भी लेट हो गया आने में। अच्छा ठीक है, मैं चलूं?
बाय दादी, सी यू।
मेरी बंटी।
बड़ी मुश्किल से पीछा छूटा और आखिरकार मैंने पल्ला झाड़ा। भगवान तेरा लाख लाख शुक्र है। एक आस के सुझाव को अपना कर मैं कर तो सकी। अब मिला सारी परेशानियों से छुटकारा। बोझ हल्का हो गया। असली मुसीबत कोई छोड़ आई। अब सब झंझट खत्म। कदम नई खुशहाली का। अब सब बराबर हो ही गया।
इतनी सुबह सुबह रहा नहीं जा रहा क्या? कहो तो अभी आ जाओ।
अभी क्या? कभी भी आओ आज से। पर आई जो तुमने बोला। अच्छा सुनो, बाद में बात करते हैं, बच्चों का कॉल आ रहा है।
हेलो।
हाँ बोलो बंटी।
कहाँ हो आप? हमने हर जगह ढूंढा, दादी कहीं भी नहीं है। घर में भी नहीं और बाहर भी नहीं।
अरे ऐसे कैसे हो सकता है? गई तो गई कहाँ?
मालूम नहीं।
अच्छा चिंता मत करो, मैं आ रही हूँ। पोहा रखा है, गरम करके खा लेना। और हाँ, सोनू को दूध पिला देना याद से। और कपड़ों की डिलीवरी टाइम पे करना भूलना मत। बाय
बाय।
दवाइयाँ तो दी ही नहीं, ये पास ही रह गई।
आइए अम्मा, क्या लेंगे?
ये कौन सी जगह है? मैं कहाँ हूँ?
मंदिर है ना अम्मा।
मंदिर? लेकिन मैं यहाँ कैसे आई?
लोग दर्शन देने को आता ना, आप भी उसी लिए आए होंगे।
पर मैं कैसे आई?
अब ये मेरे को कैसा मालूम होगा अम्मा? ये तो आप ही को मालूम होगा ना।
मैं किसके साथ यहाँ आई? कौन ले आया मुझे यहाँ?
ऐसे कैसे? किसी के साथ तो आया होगा ना अम्मा।
हाँ, कोई तो था, पर कौन था मुझे याद नहीं आ रहा है। क्यों मुझे याद नहीं आ रहा है? कुछ याद नहीं आ रहा है, पर मैं इंतजार तो कर रही हूँ। पर किसका? कोई तो आने वाला है मुझे लेने।
तो काम कर रही अम्मा, आप घबराइए मत। आप है ना आराम से इधर बैठिए, हैं? मैं आपके लिए है ना इडली चटनी और कॉफ़ी शक्कर डाल के भेजता हूँ, हैं? कॉफ़ी बना है, शक्कर वाला कॉफ़ी पिएगा ना तो सब कुछ धीरे धीरे याद आएगा, हैं?
अरे अरे हाँ, ये क्या? आज तो इतना कम? आज तो सबसे कम, वो भी छुट्टी के दिन।
मम्मी ने तो इतना ही दिया।
वही तो तुम्हारी मम्मी अब से अच्छे से देगी सब कुछ। अच्छा सुनो, ये लो
लॉलीपॉप।
तुम तीनों के लिए, मम्मी को मत देना। अच्छा तो मैं दूंगा खुद।
थैंक यू अंकल।
क्या अन्ना, आज घर में नाश्ता नहीं दिया क्या?
अरे बड़े साहब का दौरा था, थाने के लिए निकल गया जल्दी। अरे इनको भी कुछ दो, या हो गया इनका? देख रहा हूँ काफी देर से ऐसे ही बैठी।
ये अम्मा तो कब से इधर ही है। 4 घंटा तो मेरे इधर बैठ के हो गए। कब से बोल रही है कोई आने वाला है, लेकिन इनको यही याद नहीं कि कौन आने वाला है।
अरे ऐसे कैसे? ठीक से पूछो।
अरे कितना बार पूछा है ना, लेकिन कुछ याद नहीं आ रहा। कहाँ से आई, किसके साथ आई, क्या करने आई, कुछ याद नहीं। और तो और इनको तो इनका घर भी याद नहीं।
मैं देखता हूँ।
कैसे होगी, किस साल में होगी?
जी मैम, आपका ऑर्डर।
4 पूरी भाजी पार्सल।
क्या माँ जी, कहीं ऐसा तो नहीं कि नींद की बेहोशी में अपने परिवार से बिछड़ के खो गई हूँ आप, या फिर ये मंदिर की भीड़ में खो गई हूँ?
खोई तो नहीं थी, इतना तो पक्का याद है। किसी के साथ ही आई थी, पर कौन था
अरे ये तो आप कई बार दोहरा चुकी हैं माँ जी। कोई तो आया होगा ना लेकर के आपको यहाँ। अकेले तो आप आ नहीं सकती। क्यों? बेटा आया होगा, बेटी आई होगी, या फिर पति आए होंगे, या फिर बहू।
आप यहाँ बैठिए, मेरा इंतजार कीजिए। मैं बस ये पैक करवा के आऊँ। कहीं जाना मत हो।
हाँ, बहू बहू ही थी, वही बिठा के गई थी। हाँ, वो बहू ही थी जो मुझे यहाँ लेकर आई। उसने कहा था बैठी रहो, मेरा इंतजार करो, यहाँ से हिलना मत। आपका पार्सल। लेकिन कहाँ बिठा के गई?
भाई ये माँ जी की दिमागी हालत ठीक नहीं है। ध्यान रख इनका, और किसी चीज की जरूरत पड़े तो बुला लेना मुझे। और हाँ, चाय अच्छी बनी है।
जरा सा पानी मिलेगा?
मम्मी, दादी कहाँ चली गई? बोलो ना मम्मी, दादी कहाँ चली गई?
जाओ यहाँ से, काम करने दो। जाओ।
नखरे हो गए तुम्हारे। बहुत देर से देख रही हूँ, नाटक किए जा रही है। वैसे भी बहुत दूर जा रहे हैं हम। मैं अपने हाथों से नहीं खिलाते बैठूंगी। पता नहीं क्या सिखाया इन्होंने।
Pandora
ओफो, अरे ये क्या? खुश होने की वजह ये रो रही हो? अब तो सब अच्छे से हो गया, फिर ये आंसू?
ये मुझसे क्या हो गया? बहकावे में आके मैंने कैसा घिनौना काम कर दिया।
अरे क्या हो गया तुम्हें? क्यों ऐसे बोल रही हो? तुम ही तो बड़बड़ती रहती थी। बच्चों के यूनिफॉर्म, स्कूल की फीस, माँ जी के डायपर्स।
मत्ती मारी गई थी मेरी, अच्छे बुरे की सुध-बुध खो बैठी थी। क्या सूझा जो तुम्हारी बातों में आ गई?
और कोई चारा भी तो नहीं था। तुम ही तो इस मुसीबत से तंग आ गई थी, छुटकारा पाना चाहती थी हमेशा के लिए।
ये भी तो कोई रास्ता नहीं था।
यही एक रास्ता था, वो भी आखिरी।
पर ये भी तो कोई हल नहीं था। अगर हमारे शरीर के किसी भी हिस्से में समस्या आ जाती है तो हम उसे काट के फेंक थोड़ी देते हैं, बल्कि उसका सही तरीके से उचित इलाज कराते हैं। और ये तो मेरी सास थी, जिन्होंने मुझे माँ जैसा प्यार दिया, मेरे हर बुरे वक्त में मेरा साथ दिया। और आज उनकी अल्जाइमर्स की ऐसी अवस्था में, जब उन्हें सबसे ज्यादा प्यार और अपनेपन की जरूरत है, तब मैंने अपनी जिम्मेदारियों से मुंह फेरकर उन्हें तन्हा, बेसहारा, तड़पता हुआ छोड़ दिया। कौन जाने, कल वक्त और हालात के साथ ऐसी अवस्था हमारी भी हो जाएगी। तब कोई हमें त्याग दे तो तब क्या होगा विकास?
लगता है पूरी तरह मैं तुम्हें कभी समझ ही नहीं पाऊंगा। तुम्हारी परेशानी देखकर ही मैंने ऐसे करने का सुझाव दिया था। तब सोचा था कि ऐसे करने से तुम चैन से रह पाओगी। लेकिन मैं ही गलत था। लाख चाहकर भी तुम उनके बिना नहीं रह सकती। भले न कह सको, न सह सको और न ही रह सको।
क्या फायदा, अब तो बहुत देर हो गई।
देर नहीं, यूं कहो सही पल अब आया है।
चलिए चलो विकास।
क्या हुआ? क्या हुआ? अरे क्या हुआ?
माया नहीं है।
क्या?
यही तो थी, यही बैठा के गई थी। कहाँ भी था, कहीं मत जाना, इंतजार करना मेरे आने तक।
कहाँ आने वाली थी? चलो। अरे भाई। अरे छोटू, ये जो है ये अपनी सांस को वहां बिठा के गई थी। कुछ मसलों में फंसी तो टाइम पे लेने नहीं आ पाई। अब हम उन्हें लेने आए हैं और जहां बिठा के गए थे ना, वहां वो है नहीं, तो थोड़ी टेंशन में।
अरे बोमा जी, कल बेचारी इंतजार कर करके बेहाल हो गई, पर किसका इंतजार कर रही थी ये नहीं मालूम। कहाँ से आई हैं, घर का पता क्या है, कुछ भी तो नहीं मालूम।
वही।
बड़ी मेहनत की हमने, बड़ी मुश्किल से उन्होंने बताया। सिर्फ इतना ही कहा, बहू
बड़ी मेहरबानी होगी, किसी भी तरह उनसे मिलवा दीजिए।
एक बार उसके पास ले जाइए।
ओ माँ, क्या है? मैं लेके जाता है ना आपको।
ये फिल्म समर्पित है मेरी दादी को और उनके साथ ऐसे उन सभी लोगों को जो कि एल्जाइमर्स और डिमेंशिया जैसे मानसिक रोगों से त्रस्त होकर उनकी गहराइयों में खोते जाते, अपनों से और अपने आप से दूर होते होते एक लंबे सफर पर निकल चुके हैं। वो सभी लोग जो इस भयंकर व्याधि से जूझ रहे हैं, दिन रात और हर वक्त।
Sir, can we please have you on stage for a little bit of experience sharing with the movie, and we'll also take audience questions. Yes, sir.
Thank you so much. Thank you, thank you. Well, I am really overwhelmed, and I thank ARDSI from the bottom of my heart, especially Narendra ji, Renu ma'am, Veena ji, Dr. Manjari, and Dr. Ronnie for giving me this platform to showcase this film to all these dignified individuals. I am really privileged that Dr. Mohan Agashi has witnessed my film. I really feel honored. Well, first and foremost, I have been seeing life from a different perspective post-COVID. Life had become a little ironical. The moment people started spending time with their loved ones, they started distancing themselves from them. And these were these so-called social media influencers. So, you know, as a responsible art lover, after having received so much love from the audiences, I felt, you know, the need to give it back to the audience. And what a better platform than showcasing films, hope stories on mental health. And I intend to keep on doing such films in the near future. I am green lighting a few subjects again on mental health awareness, and receiving such a warm response was indeed a privilege, and it resonated well with you know, Dr. Meera's speech and all the dignified people out here. There is a need for change, and we are doing it through cinema. So thank you, sir. Thank you, everyone. Any questions if you would like to ask? I have said it all through the film, so. Thank you so much. Ma'am, the thing is that I did not wait for any personal experience. I was sensitive about things that were happening around me, and it just gave me enough fuel to, you know, take such stories, and I intend doing much more stories on mental health awareness. Yeah. Thank you, ma'am. Means a lot.
Well, first of all, congratulations.
Thank you, doctor. Such an honor.
Congratulations, not because only you have made a film on mental health or Alzheimer, because you have made it so well.
Thank you, doctor.
And so good that it appeals, right? Many times what happens, good intentions do not necessarily get portrayed so well, right? So congratulations on that. So my question is, mental health is a vast field. Alzheimer is just a part of it. There are a lot of severe mental health problems as well as minor mental health problems. In fact, the major problem in mental health are minor problems. They are huge in number and they don't get attended to, particularly in the media. Of course, severe mental health problems do get portrayed, but more often than not, they are used only for dramatic impact, so as to spread misunderstanding about mental illness and create problems both for the caregivers, for the patients, and those who try to treat them. In fact, many popular films, the portrayal of mental illness is only for the dramatic impact. Both the professionals are shown in that light and also the patients. They are used more to generate a comedy than to raise a question to make you think about it. Is more to get rid of the problems and shell them under the carpet. So illnesses like bipolar, schizophrenia, Alzheimer, or related mental disorders are ignored by good filmmakers. And a lot of time the reality is compromised for entertainment. What you have done is, you have not compromised the authenticity of the problem, but still have kept the audience on hold to see and make them think. So how did you choose? Have you made any other films on other mental health problems?
No, doctor. Actually, this is for starters. This is what I felt. I was doing a film with Yashraj and Padmini ji, the youngest 87-year-old lady, was my co-actress, and the film was blossoming. And once I interacted with her, I thought I found my Kaushalya and the need to do it.
So how did you come to a point that let's make a film on Alzheimer, not on schizophrenia, not on bipolar, or not on any other issue?
Complete awareness of mental health struck when people around me started saying, "Buddha satiya gaya hai," and then I realized कि वो सटिया नहीं है, सटिया है आप है. You have your brains at the right place, and the poor people don't even know that they are affected. So I thought the real need is for us to wake up and do something, and what better than a film.
I absolutely admire you, adore you for doing, and do keep on. Do make other films also.
Yes.
But do make films which will make people think and dispel the myths and the misunderstanding about mental health.
Thank you, doctor. Doctor, life comes a full 360. I started my career with a Marathi film called Kaidyacha Bola with you, and here I am talking to you. So it's an honor, and this will push me to do many more films on mental health. I'm green-lighting many more films on mental health issues.
Thank you.
And I'm honored to talk to you.
I'm sure it will be shown very widely and accepted.
I'll try my best. Thank you. Thank you so much, doctor. Thank you, everyone.
By the time they load my film, I'm not going to introduce the films. The films are made so that one doesn't have to speak. But only to tell you, what do we have to learn from films? We are taught what Alzheimer is, what schizophrenia is, but each case of Alzheimer is different than the other. So these are representatives. Like this is a fortunate lady we have seen with Alzheimer. We'll say another fortunate father, probably. But many a times, the cases are not as fortunate as they are seen. And the whole idea is why to make other people think is to appeal the human in them. The formal education have made us very logical, and we need to be illogical in order to be affectionate and loving. This film which we are going to see now is based on the true experience of the filmmaker, who is not here today because he is in Chennai showing his film. And he has been nursing his own father, who has been a patient, who is a patient of Alzheimer for several years. And probably this is to get out of his system that he has made this film, and which is completely different than such a lovable film which you have made. Thank you. And it's another short film of 25 minutes in which I happen to act. Thank you.
So as much as we enjoyed the movie, we also enjoyed this cute little banter between two filmmakers here. And Dr. Agashe sir,
I just want to share my experience. May I?
Yes, ma'am, please.
I'm working as a social service superintendent in Regional Mental Hospital, Nagpur. My name is Sandhya. और मेरी मदर लास्ट ईयर उनकी डेथ हो गई. शी वॉज सफरिंग फ्रॉम पार्किंसन विथ अल्जाइमर डिमेंशिया. आज पूरी फिल्म देखते देखते मैं बहुत रोई. इतना मेरी मम्मी के लिए मैं बहुत कुछ नहीं कर पाई. मुझे सब मालूम था, मैं भी इसी फील्ड में काम करती हूँ. बहुत सारे लोगों को मैं बातें बताती हूँ, या ऐसा करना चाहिए वैसा करना चाहिए, लेकिन मेरे घर में मैं ऐसा कुछ नहीं कर पाई. मुझे बहुत ख़राब लगता है. समझता था और बार बार मैं बताती थी, लेकिन उनको लगता था कि मम्मी कुछ नाटक कर रही है. ऐसा फिल्म में दिखाने के बाद में फिर मुझे ऐसा लगा कि मैंने ये मेरा एक्सपीरियंस शेयर करना चाहिए. एक्चुअली लोगों में अवेयरनेस होना बहुत ज़्यादा ज़रूरी है, और उसी के लिए मैं भी काम करती हूँ. लेकिन फिर भी मुझे लगता है कि काम बहुत थोड़ा सा है, काफ़ी करने की ज़रूरत है. और अवेयरनेस मतलब हम लोग सिर्फ लेक्चर दे तो अवेयरनेस काफ़ी नहीं हो सकता. ऐसे कुछ फिल्म के द्वारा अगर अवेयरनेस होता है तो ज़्यादा से ज़्यादा लोग देखकर और बहुत कुछ सीख सकते हैं. तो थैंक यू वेरी मच सर कि आपने इतनी अच्छी फिल्म बनाई, और मुझे ऐसा लगता है कि ज़्यादा से ज़्यादा लोग देखें, ज़्यादा से ज़्यादा लोगों तक ये बातें पहुँचे, ताकि आने वाले लोगों में एटलीस्ट अवेयरनेस रहे और पेशेंट की केयर बहुत अच्छे से हो सके. थैंक यू वेरी मच.
I am requesting all those besides wishing the best, please try to make effort to organize at least one screening and call him, or even without him, get the right kind of audience to see this film, particularly those who are completely away from the problem and don't think such problems exist. So my appeal to you is try to organize one screening, though not many, at least one screening of such film, or help him to sell his films to any of the OTT platforms. Thank you very much. You must have sold it already.
Thank you, ma'am, for sharing that very personal experience. And I think, sir, it's really your moment for the day. I request Dr. Agashe, sir, to please felicitate you. So please.
This went to Kanpur, I know his problems because I have faced these problems for 10 years. You make these films people wish you, but actually do something about it, only then wish you.
Let me ask you, what's your inner voice saying? Because he's voiced it all for you today, right?
Well, I honestly feel that hopefully I get an opportunity to work with Agashi sir in my next film and screen it here in 2024.
He's using this platform well.
No.
Thank you so much, sir. We'll now begin with Dr. Mohan Agashi sir's film.
Perfect. हाँ भैया, कैसी तबीयत है मम्मी की?
तबीयत ऑक्सीजन पे है।
क्या मतलब?
पल्मोनरी एम्बोलिज्म। वो सर्जरी के बाद नो लेग मूवमेंट की वजह से ब्लड क्लॉट फॉर्म हो गया और वो ट्रैवल करके लंग्स पहुंच गया।
तो डॉक्टर्स क्या कह रहे हैं?
अभी ब्लड थिनर्स और क्लॉट डिसॉल्वर्स दिए हैं, लेकिन मम्मी को डायबिटीज का भी इशू है ना। अभी रिपोर्ट्स आना बाकी है। एक बार डॉक्टर आएंगे राउंड्स पे तो मैं अपडेट करता हूँ।
ठीक है भैया।
अच्छा, तुझे कितने बजे जाना है? एक मिनट।
ओह शिट।
एक काम कर, तू ब्रेकफास्ट कर ले फिर मुझे कॉल कर।
नहीं भैया, आप कुछ कह रहे थे ना?
मैं कह रहा था तुझे कितने बजे काम पे जाना है?
जाना तो था भैया। एक काम करिए ना, आप मम्मी के पास रुकिए, मैं पापा के पास रुकता हूँ। आज का कैंसिल कर देता हूँ।
श्योर।
पापा चलिए, उठिए, चलिए पापा। चलिए, आ जाओ। क्या? आ जाओ, आ जाओ, चलो 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 चलो, उठना पड़ेगा। आ जाओ, आ जाओ। कोई बात नहीं। आई आई, आ जाओ, आ जाओ, आ जाओ। हाँ, कोई बात नहीं, कोई बात। बस 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 बस। बाहर देखिए कितना अच्छा मौसम है, कितनी प्यारी धूप खिली है ना। चलिए, ये लीजिए दवाई खाइए, ये लीजिए। क्या है? हैं? क्या? ये लीजिए, दवाई लीजिए। चलो, नो 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 नो। पापा दवाई तो खानी पड़ेगी ना। लो दवाई पापा, लो। हाँ हाँ, मुंह में, मुंह में, मेरे नहीं, अपने अपने अपने। नहीं 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 नहीं, पापा क्या कर रहे हैं आप? देर हो रही है, जल्दी कीजिए ना। हाँ चलिए दवाई खाइए, फिर बाथरूम भी जाना है, नहाना भी है, और फिर मम्मी को भी तो देखने जाना है। हाँ आपको पता है ना, मम्मी का ऑपरेशन हुआ घुटनों का। हाँ जाना है ना उनसे मिलने, है ना। लीजिए, लो पानी लो। लो। हाँ क्या है, क्या पानी है, पानी लो, दवाई लो। क्या क्या, अच्छा लो, ये लो। समझ गया। लो लो, चलो। अंदर अंदर अंदर, दिखाओ 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 दिखाओ, क्या कहाँ है, दिखाओ दिखाओ। अच्छा कोई बात कोई बात कोई बात, ठीक है। कोई बात। पापा आइए, चलिए चलिए आइए। पापा चलिए, मम्मी से मिलने जाना है, चलिए आइए, जल्दी कीजिए, मम्मी ने बुलाया है। वेरी गुड पापा, आइए। अरे अरे पापा वहाँ कहाँ जा रहे हैं? पापा वो बेडरूम है, बाथरूम इधर है पापा। हाँ आइए। हाँ चलो, क्या, चलिए चलिए चलिए, देख के सीढ़ी है, चलिए। क्या हो?
सब देख रहे,
सब देख रहे।
4 लोग हैं।
4 लोग, अच्छा अच्छा, आप यही रहो। ये देखिए। हाँ भाई क्या कर रहे हो, चलो बाहर चलो। और तुम यहाँ क्या कर रहे हो, चलो तुम भी बाहर चलो। हाँ हाँ, आपसे कह रहा हूँ मैं, चलिए बाहर चलिए। और आपको दिख नहीं रहा कि पापा आए हैं यहाँ पे? चलिए बाहर चलिए आप। हाँ हाँ चलो। गए पापा, आइए। हाँ? क्या, मैं हूँ पापा, आपका छोटा बेटा, लिटिल है, लिटिल है ना। चलिए आइए। हाँ क्या, अच्छा अच्छा, ठीक है ठीक है। ये इसको ऐसे उतारना है, इस पे ऐसे बैठेंगे। हाँ ठीक है, जैसे कल किया था, है ना, कल किया था ना। हाँ ठीक, मैं यही हूँ। हाँ ठीक है। हाँ। क्या क्या हुआ? हाँ बाथरूम नहीं आ रहा? हाँ अच्छा कोई बात, चलिए आइए, ब्रश कर लेते हैं। हाँ अपना ब्रश लीजिए। अरे वाह पापा, आपने तो अपना ब्रश ले लिया है। आइए पेस्ट लगाते हैं, चलिए। ये ऐसे, ठीक है। अब ऐसे ऐसे अच्छे से, पीछे पीछे, ऊपर नीचे ऊपर नीचे। हाँ कुल्ला कुल्ला करो, कुल्ला ऐसे ऐसे कुल्ला। अरे पापा कहाँ जा रहे हैं, कुल्ला कीजिए ना, अरे क्या पापा, पानी तो है, पानी है पापा। अरे 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 क्या पापा, लड़ाई थोड़ी तो हो रही है। चलिए आइए, चलिए हाथ लाइए। हाँ 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 चलिए। हाँ 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 चलो चलो। हाँ आ जाओ आ जाओ। चलो चलो। बस बस हो गया। अरे पापा, सारा हाथ गंदा कर लिया आपने। लाइए हाथ लाइए, चलिए। चलिए रगड़िए, चलिए पानी के नीचे डालिए हाथ, पानी के नीचे डालिए हाथ। पापा 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 मुंह पे नहीं पापा, हाथ पापा, हाथ धोना है, हाथ। हाँ भाई, आई एम सॉरी यार, मैं आ नहीं पाऊंगा मुझे लगता है।
क्यों भाई, क्या हुआ?
यार मम्मी को पोस्ट सर्जरी कॉम्प्लिकेशन हुआ है और पापा को अकेले छोड़ के आ नहीं सकता।
आई अंडरस्टैंड, पर ऐसे लास्ट मिनट में मीटिंग कैंसिल करना, कितनी जुगाड़ लगा के मीटिंग सेट करवाई थी यार, सारा इंप्रेशन खराब हो जाएगा। एंड दिस मैन इज सो बिजी, आई डोंट नो व्हेन ही विल गिव अस टाइम अगेन।
आई अंडरस्टैंड यार, बट
देन फिगर आउट मैन। चल मैं थोड़ी देर में बात करता हूँ, ठीक है?
फिगर आउट हाउ ब्रो?
अरे थिंक अबाउट इट, 13 years already in the industry now. When will you finally make your film? सोच और बता, ठीक है?
बस 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 बस, चलिए आइए। पैर साफ करा दीजिए, गंदा हो रहा है। लाइए 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 लाइए। अरे पापा गंदा हो रहा है, साफ तो करना पड़ेगा ना। पापा गंदा है, साफ करना पड़ेगा ना। चलिए आइए। कोई बात नहीं, ये देखिए गंदा है ना।
कंप्लेन करता हूँ तेरी।
हाँ चलिए आइए, उठिए, चलिए चलिए चलिए, उठिए चलिए। कपड़े बदलने पड़ेंगे ना, सब गंदा हो गया। चलिए लाइए। बस 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 हो गया, बस 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 हो गया हो गया हो गया। बस एक मिनट, हाँ एक मिनट, बैठिए बैठिए बैठिए। एक बात, बस बस हो गया हो गया, बस एक हो गया बोल रहा हूँ ना। एक मिनट, हाँ मुंह साफ कर दो, मुंह पापा ये गंदा हो रहा है ना। हाँ हाँ बस 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 ये ना 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 बस हो गया ये देखिए। कहाँ जा रहे हैं पापा? कहाँ जा रहे हैं पापा? ये ऐसे नहीं खुलेगा। तो कुछ खा तो लीजिए, आपने सुबह से नाश्ता भी नहीं किया। कहाँ 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 जा रहे हैं?
हटा।
कहाँ जा रहे हैं?
हटा।
कहाँ जा रहे हैं आप?
नहीं हटोगे?
नहीं हटूंगा, नहीं हटूंगा,
हटा।
नहीं हटूंगा,
नहीं
हटूंगा, नहीं हटूंगा, नहीं हटूंगा, नहीं हटूंगा। चलिए पीछे, चलिए पीछे, चलिए पीछे, बैठिए।
मारता है मुझे, मारता है।
हाँ मारता हूँ।
हाँ?
बैठे रहिए चुपचाप, बहुत ताकत है ना आपके अंदर। पापा बहुत हो गया यार, बहुत हो गया यार। पैर पड़ता हूँ यार आपके। नहीं खोलूंगा, नहीं खोलूंगा, नहीं खोलूंगा पापा, नहीं खोलूंगा, नहीं खोलूंगा, नहीं खोलूंगा। चलिए बैठिए यहाँ पर, बहुत हो गया आपका पापा, बहुत हो गया। चलिए बैठिए। क्या है? भूल गए मुझे आप पापा? हाँ हाँ, ऐसे ही हंसते रहा करिए, है ना? मैं आपका रिटर्न हूँ ना, हूँ ना? हाँ, तो फिर क्यों जाना आपको घर के बाहर? पापा कहाँ जा रहे?
स्टेशन।
हाँ हाँ, आइए इधर है स्टेशन, आइए आइए। पापा कहाँ जा रहे हो पापा? पापा स्टेशन उधर है। पापा 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 साइड में चलिए ना पापा। बन के रुकिए पापा, कितना घुमाएंगे? पापा वहाँ नहीं, ये पापा।
बेटे कैसे हो बेटे? चलो साथ घूमने जाएंगे, खाना खाने जाएंगे, चलो साथ खाना खाने जाएंगे।
पापा मुझे दे दीजिए, लाइए लाइए। खाना खिलाना आपको, घर से अच्छा ठीक है ठीक है, ये साफ तो करा लीजिए। मस्त गर्म हो गया है। पापा कहाँ जा रहे हैं आप? शैम्पू लगा हुआ पापा बालों में।
तो तुमको क्या हुआ? कौन हो तुम?
अच्छा एक मिनट रुकिए, एक मिनट इधर आइए, आराम से इधर आइए। देखिए शैम्पू में बालों में शैम्पू लगा हुआ है, वो तो हटाना पड़ेगा ना, नहाना तो पड़ेगा ना, हम नहाते थे ना, है ना? तो पानी डालते हैं, ठीक है, शैम्पू हटा देते हैं, लाइक अच्छा हाँ, ताकत नहीं, थोड़ा सा शैम्पू छोड़ा। पानी से डर लगता है आपको? बोलिए ना, पानी से डर लगता है आपको बाबू? कोई बात नहीं, मैं आपको नहला देता हूँ। आपको याद है आप पहले दिन में 2-2 बार नहाते थे, 2-2 बार, हाँ? हम दोनों साथ में नहाते थे, याद है आपको? है ना? कितना मजा आता था। चलिए। अरे क्या हुआ? मारता है? नहीं पापा, नहीं मारूंगा।
ऐसे नहीं इसके।
हाँ पापा, आपकी गीली हो गई ना पापा, गंदी हो गई। चलिए साफ कर देता हूँ, है ना? फिर आपको साफ सुथरे कपड़े पहना दूंगा, मेरी जिम्मेदारी है ना? हम नहाते थे ना पापा, है ना? याद है? मुझे लगी चलिए थोड़ा सा साबुन लगा लेते हैं। घूम जाइए बस हो जाए। मजा आ रहा है ना? अच्छा।
ऐसे नौकरी करता है तो? अब पुलिस बुला तो अंदर करता हूँ तुझे।
अच्छा
नहीं मानेगा।
तो जुला लेंगे आप, हैं? अच्छा लीजिए करिए मुझे गिला। गरम। अब तो आपने मुझे नहला दी, अब तो आपको भी नहाना पड़ेगा पापा। वो देखिए पापा, नहीं सच में। लो पापा बता दो मम्मी को कि हमने कितनी मस्ती की। मम्मी को बताओ। मम्मी
ये मम्मी नहीं है
क्या? इतने सालों से आपने ये राज हमसे छुपा के रखा मम्मी, है भैया, कि ये हमारी मम्मी नहीं है? ओ पापा, एक मिनट मम्मी, एक मिनट। पापा मैं कर दूं? मैं कर देता हूँ, ठीक कर देता हूँ। हाँ देख रहे हैं कितना बढ़िया स्वेटर है। बहुत सही। एक मिनट पापा, एक मिनट मम्मी, जरा पापा को तैयार कर दें। तेल है पापा। अब आएंगे कंघी। ये और ये। अब है ना? ये देखिए पापा, आप कितने हैंडसम लग रहे हैं।
चिट्ठी लिखेंगे, तुम्हारा प्रमोशन हो जाए।
ओह अच्छा, मेरा प्रमोशन करवाएंगे आप? मम्मी सुन रहे हैं भैया, मेरा प्रमोशन करवा रहे हैं पापा।
हाँ बेटा, हो गई तेरी तरक्की।
हाँ
पापा, फिर तो मेरे स्टार्टअप के लिए 1 करोड़ का लोन पास कर दोगे ना?
हाँ कह रहे हैं हाँ।
बीवी बच्चे?
पापा मेरी तो अभी शादी भी नहीं हुई। नहीं तो क्या हो गया पापा? कोई नहीं, कोई नहीं पापा।
सुंदर लड़की?
अच्छा, ऐसी सुंदर लड़की दिलवाएंगे आप मुझे, हैं? देख रहे हैं मम्मी, पापा पापा कह रहे हैं कि मेरे लिए ऐसी सुंदर लड़की ढूंढेंगे। ओ मेरे पापा, ओ मेरे पापा।
I don't want to say anything. I think we all would want to stay in the moment. And we'll hand over the mic to you, sir. Please take over.
Well, I've just acted, as you know, in the end of the film, you see his real father, whom he has been nursing. And this is his own experience, and you know how much patience and love is needed as a caregiver for a father like this. Thank you very much. Pratik Srivastav is the director and writer of this film, and currently he's in Chennai, where this film is showing. Thank you.
So what is the name of the movie? What is the name of the movie they are asking?
What is the name
Name.
of this film?
Ah.
My Father is Afraid of Water. That's the name of the film. He is afraid of water.
Thank you so much, sir. I request Dr. Vatwe, sir, to please felicitate Dr. Agashe, sir. Thank you for this beautiful evening, sir. Thank you very much.
I think the image speaks much louder than the words. And I think you will carry home the images of both the films, and then probably it will bring about some change in the attitude. Thank you.
Anybody wants to ask anything to Sir? He's open to receiving questions.
Well, there are a couple of people, I mean, the representative of different dementia care unit, you know, the caregivers present here. There are people who have taken care of their respective parents, relatives who were suffering from various kind of elderly issues. What I would say, we have a 60-bedded facility in Chaitanya. Those who are, we know, we are taking care of patients with the dementia and Alzheimer's. When I reach there in the morning, this is what I exactly hear there. Ludwig, come here. Don't go there. Please come. Do this. You know, it requires a lot of patience. It's a, you know, running a facility is okay. Anybody can run a facility, but if you run a facility with dignity, and if you want to honor your respective patients, this is exactly what, like a family member. See, this kind of work going, you know, every day. This is not going to be one day affair. This is going to be every day, probably deteriorating day by day. Unless and until a family member is there, even to us, you know, at times, even family members feel, I'm fed up. You know, they feel that really they are into a helpless situation. So, sir, it was an excellent movie. And if the writer, director were here, we would have conveyed that message. Since he is in Chennai, convey our best wishes. And, you know, it is really, as a family member, whatever one can do towards their parents, exactly it is shown there. And as a patient with the dementia, you played a typical role, which we are seeing on a daily, I mean, our day-to-day activities. So, each and every staff members who are working in our Madhurchaya and Pitruchaya, please go home with this message. This is how you need to take care of our patients. And, you know, we I really appreciate your patience, whatever you do there. There are, you know, exactly this is what you go through on a daily basis. It was for his father, but you are doing it for someone else's father. It's a big salute to all my team members who are in dementia care unit. Of course, not only that, those who are working in mental health also. You know, I make this opportunity to thank you and salute you for what you do for our residents. Thank you.
Thank you everybody for all the energy and enthusiasm throughout the day. I promise to return back tomorrow with equally exciting sessions. We start tomorrow sharp at 10 o'clock. Thank you everybody.